really comfortable with the pathology. And that has to be a key. Now, do you have your study guides with you?
Yeah, I have like my Kettering workbooks, but I was planning to probably purchase something else like the Lindsey Jones or the Respiratory Bootcamp just to give myself a different look. But I still have the old stuff as well.
Oh, I know how you feel. I've seen a lot of times how people seem to think that that's a better way. I would tell you that we're giving you everything you need.
Okay.
But I understand sometimes you just think it's just not clicking. I've got to try something different. And there's some logic in that too. Um, but I have found that that can also cause things to be very confusing for people too, because they'll use different values, different things, and things that you feel comfortable with now, they could be questioned or come into question. I have found that, Lindsey Jones, if that works for somebody, I don't tell them to switch from Lindsey Jones to go to us. If it's working, I say stay with one type of exam prep. If there was a particular area, and I told you pathology, if there was a particular area that you felt you were you were really weak in, what would that be?
Um, I really don't know, honestly. And the reason I say that is because, so from my experience, I take practice exams and stuff like that, and I do pretty well on them. And then I go to a test and I kind of like freeze up.
Right?
So I don't really know where I'm struggling at.
Okay.
Um, I know spirometry is something that I still struggle with a little bit, but after taking my test, I've only seen maybe one question on that. It
Yeah,
hasn't
it's not
been
a
much.
heavily tested area. You're right. You wouldn't see a lot of questions on spirometry. I think it maxes between 6 and 8 total.
Hmm.
So it's not a major focal point of the exam, especially because they have another credential, they being the MBRC.
Yeah.
Um, Key areas that I know that are very, very important on the exam, patient assessment. Do you know patient assessment? Do you know normal? That's what the key is, because if you can't identify normal, you can't identify what's wrong. And I'm not
Hmm.
here to put you on a hot seat, but if I just started asking you, what is normal this? What is normal that? What is normal this? You know, you have to be able to answer those questions just very quickly.
Right.
Now, the MBRC, you'll notice in the very beginning of our book, I think it's page A4, that's the four life functions. Can you turn to that for me?
Yeah. A4. And just to let you know as well, just to kind of give you an update. So after I failed my exam the last time, I took like a month break.
Okay.
So today is actually my first day back, kind of like getting back into things.
Well, I would tell you your desire to go ahead and first off coming back and taking a look at it. There's nothing wrong with taking a little time,
Hmm.
lick your wounds, and but that you came back and trying. That's going to be really important. Um, Having a really good plan, a solid plan coming back is going to be the key. And I don't think you need to spend any more money. I really don't, because people will pass. They just have to be able to know the basics
Okay.
and feel very comfortable. Now, we're going to start on when I was talking about, knowing normal, and then I told you to turn to page A4 in
Hmm.
the study guide. That should be the four life functions. Is that correct?
Yeah, correct.
Okay. I don't have my book in front of me. I'm just going by memory.
Okay.
Now, A4 at the top, you talk about, you know, uh, ventilation, oxygenation, circulation, and perfusion. I think if you come down to C, it starts talking about vital signs.
Vital signs.
It talks about like for ventilation, these are the things that you would look at.
Oh, right, correct. So
All right.
ventilation is like respiratory rate, tidal volume, chest movement.
Correct. All of those are like assessments. And when the MBRC gives you a question and they put that information into the question, then what ends up happening is you need to be able to identify Are they normal? Or what's abnormal? But first you have to know what normal is. So all of those that are listed there, let me see if I have mine here. Put it up before. Okay. I just got back from California. I wasn't sure if I still had it in my luggage.
You're good.
So when I'm looking at that page, the assessment of the patient, this is measuring the 4 life functions, vital signs. You see all of those listed after ventilation, all of those listed after oxygenation, circulation, and perfusion. That's the kind of information the MBRC would give you in a question. They might give you something about the respiratory rate. They might give you something about the heart rate and sensorium. They might tell you, the patient's blood pressure is this, or, their breath sounds are that. You had to know what normal was, because when they give this to you, some of it's going to be normal, some of it's going to be abnormal. When you identify all the abnormal things, then you have to prioritize them. Okay. So if they gave you an abnormal respiratory rate and breath sounds, and then they gave you an abnormal heart rate and color and saturation, SpO2, and their blood pressure was abnormal and their temperature was abnormal, you can just imagine a question that would have that in there. Now, because of you identifying those who were abnormal, you're going to go ahead and prioritize them. You're going to say to yourself, well, what's wrong? I identified all the things that are wrong. Second W, what do I do about it? Well, I look at all these things that are wrong, and respiratory rate, breath sounds were abnormal, and they're going to be elevated to the first thing you try to take care of. What's wrong? What do I do? When do I stop? So you identified what's wrong. What are you going to do? I got to go ahead and take care of ventilation first. And then, so you look for a ventilation answer. Now, the MBRC would give you oxygenation answers and, perfusion answers, but the MBRC is trying to get you to see if you understand which system, which life function needs to be treated first. And so you would choose a ventilation answer. The patient's not ventilating. I'm going to put them on BiPAP. I'm going to mechanically ventilate them. You got to do something to help improve those vital signs. Did you highlight number 5 in your book?
Yes, I did.
All right. All assessment and treatment are based on these life functions. All of them. Right? If you look at B, life functions identify problems and they must be treated. So you've got to know those values. And then you see the prioritization at the very bottom. Okay. Jordan here.
Yes, I'm here.
All right. Very good. Hi, Jordan. My name's Alan. And what we're looking at here is Miss Patricia asked me to go through some stuff. Richard and I have been talking about some areas where, you could do something to help improve your scores on the TMC. And the very first thing I think you guys need to make sure is your pathology. And then the next thing is you have to be able to do patient assessment. You've got to be able to do a solid patient assessment. Okay. Patient assessment, almost all the questions, unless it's troubleshooting, are going to be related to that section A in the study guide. And what I did is I started to focus on page A4 in the study guide.
Okay, yep, I'm with you.
All right, perfect. Now, let me give you guys an example. Think about this. I'm going to just think about a hospital example. Got a patient who's in the hospital. They're on a 2-liter nasal cannula. Nurse just got report saying the patient's been doing fine, satting 93% on a 2-liter nasal cannula. They talked about some of the other things that were going on with the patient, nursing care kind of stuff. And but 93% was the sat, and they're on a 2-liter nasal cannula. Nurse then goes to their pod. They go check on their patients. Everybody seems to be fine, and then they start their work. Right? They poked their head in the room and they checked on everybody. About 30 minutes into treating another patient or taking care of another patient, she hears a pulse ox going off, or he hear a pulse ox going off. They go into the room with the patient on the 2-liter nasal cannula, and now they don't see it at 93%. It's like 88%. What is the knee-jerk reaction for the nurse to do? Turn up the FiO2, right? They're going to go in there and they're going to increase the FiO2. So they go up to 3 liters and the sats are 92. They go up to 4 liters and it's 93, 94%. They leave it alone. They're happy. The sat's there. About 45 minutes later to an hour, the pulse oximeter goes off again. This time, when they go inside the room, they see the patient, they see the sats low, they might increase the FiO2, but they're going to call respiratory. They should be calling respiratory. You come in, you're look at the patient differently. You look at a respiratory therapist looks at the patient more like a physician or physician assistant. That's the way you've been trained. And you go ahead, and one of the first things that you do is, of course, you look at heart rate, respiratory rate, sat, color, level of dyspnea, breath sounds, 4 in the front, 4 in the back, 2 on the sides. You're definitely doing that. Now, when you listen to the breath sounds, they're very diminished. You're not hearing much air movement at all, a little bit of a wheeze. Can this prevention of airflow going through the airway to get to the lungs, can that cause saturations to go down? Yes.
Yes.
So what's the patient have? The patient has an oxygenation problem, but they also have a ventilation problem, right? Because they're not moving air. Very simple, very, very basic situation. So what would you recommend if they had bilateral wheezing and decreased breath sounds? Albuterol.
Yeah,
right? You give them an albuterol breathing treatment. When you give them the breathing treatment, you see the sats are 96, 97% afterwards. So then you bump down the FiO2 because they were originally on 2, but the nurse had them up to 4. The nurse identified a wrong problem with the patient. They identified that the saturation, the oxygen saturation was low. And they corrected that. It's not a bad choice, but was it the best choice? When you came in, you listened to everything. You looked at everything that was going on with the patient. Heart rate, respiratory rate, sat, color, level of dyspnea, breath sounds, 4 in the front, 4 in the back, 2 on the sides. You looked at everything, and then you identified, not only do they have an oxygenation problem, but they have a ventilation problem. And based on this hierarchy that you see on A4, I always treat ventilation first. So what did you do? You gave them a breathing treatment. It opened up their airway. When that opened up their airway, did that improve their oxygenation? Yes. That's the way the NBRC thinks. They're going to give you other answers that are not bad answers. There's just going to be a best answer. Okay. Now, I'll give you another example. The nurse gets the patient 2-liter nasal cannula. They're sat 93%. They're happy. They go on to take care of their other patients. All of a sudden, they hear the pulse oximeter go off, and the patient's pulse ox is like 79%. Breath sounds are barely even moving at all. Very shallow breathing, almost absent, and the patient's unconscious. The nurse grabs, right, a non-rebreather and puts it on the patient because the sats are so low. They identified an oxygenation problem. But what's the patient not doing? Not breathing. You need to grab an ambu bag and start bagging the patient. Even if you started to bag the patient with room air, SATs will go up because what was the problem? The patient wasn't breathing well enough. You needed to assist the breathing. Does that make sense?
Yeah.
Okay. I want you in that same study guide. Go ahead and go to J5. J is the appendix in the back, and this is on pathology. Let me know when you guys get there.
I'm there.
I'm there.
All right, very good. It should say asthma.
Yes.
Okay. Now, I'm not going to bust your chops. I swear to God, I'm not, but I'm going to bust your chops. I swear to God, I am. Okay. Either way here, I want you to kind of feel some pressure. Okay. If I told you right now, Jordan, tell Richard and I everything you know about asthma. Richard, right afterwards, you're going to tell us everything you know about CHF pulmonary edema. Would you really want me to do that?
At the
Being
moment,
completely honest.
at the
Hell
moment, nah.
no. Right?
No.
There's no way in hell that you want me to do that. Dudes, how the heck do you think you're going to pass the test without knowing the pathology? You can't, there's guarantee. I'm showing you asthma, and I'm going to teach you asthma today. I'm going to teach you asthma today. If you flip the page, look at J7, COPD. Would you want me to say, okay, Richard, Jordan, both of you, tag team, tell me what you know about COPD? I want you to tell me everything you know. If you don't have something already prepared, you're lost. You're just trying to figure it out. You're like a guy on a hospital TV show, House or something like that, trying to find all the clues. This is recipe crap. This is nothing but a recipe that you got to follow. So, Richard, I don't know if you heard, pardon me, Jordan. Oh, it's Ruben. Sorry, Ruben.
That's fine. Either one is fine.
All right. Well, your first name's Ruben, right?
Yeah, but some
Okay, Ruben's great. Okay.
Okay.
There's these three W's that I've created. My invention. All right. Whenever you're looking at a problem, you have to identify the first W. What's wrong? The second W is you have to decide what are you going to do about it? And the third W is when do you stop? What's wrong? What do I do? When do I stop? What's wrong? What do I do? When do I stop? And I do that over and over again. Every problem. Patient's got bilateral wheezing. What's wrong? They got bilateral wheezing. What am I going to do? I'm going to give them oxygen and I'm going to give them a bronchodilator. When do I stop? When they're no longer
having that
wheezing.
Issue. Yeah.
All right. So let's look at asthma. I want to kind of get you guys in my head on how I would study asthma. Number one is the definition. That's kind of nice to know. All right. We have need to know, nice to know, trivia. Right? If you ever want to do a sputum bowl or some kind of game, there's trivia. So the very need to know and the nice to know or good to know, those two areas you really do need to know. So let's look at this definition. I'm going to break it down. And so if you told me you both are going to go study this Friday, both of you are taking off from work, or Wednesday, taking off from work, and you're going to spend the day studying, I would tell you that's great. I want you to start studying your pathology. And I don't want you to hear when you and I talk again, say a week from now, you said, I studied all the pathology that day. Well, that's great. I'm never going to discourage you. It's not the smartest way to attack it because what ends up happening is everything starts to get jumbled all up. You mix it all up in your head. So what you need to do is focus on something really, really well. So we would just focus on asthma instead of having all these pathologies that you're very familiar with, but know none of them. I know a little bit about this. I know a little bit about CF. I know a little bit about myasthenia gravis. I know a little bit about Guillain-Barré. I know a little bit about congestive heart failure, extra fluid, give them Lasix. You know some of these basic stuff, but you don't have enough knowledge to really feel confident. All right. So that leaves you confused. And the MBRC likes to give a bunch of other information or other answers that lends itself to having the students feel very uncomfortable. So I'm going to go through asthma. If I said, I want you guys to know asthma first, hands down, both of you have taken the test. Were there asthma questions? Yes. Lots of asthma questions. Flip the page. Were there lots of COPD questions? Yes.
Definitely for COPD.
Yeah, both of them. And both for pediatric asthma too. So the thing here is you need to go into the test knowing those pathology cold. There's no way you're going to get those wrong. So I'm going to teach you some stuff right here. If I'm going to look at asthma first, then we'll look at COPD. The definition said is that it's a chronic, ongoing. When you have asthma, you're going to have exacerbations. You're going to have flare-ups. Okay. Nobody ever gets admitted to the hospital because they have asthma. They get admitted to the hospital because they had an exacerbation, a flare up of their asthma condition. Same thing with COPD. Nobody ever gets admitted for COPD. They get admitted for an exacerbation or a flare up of their COPD condition. Does that make sense? Because it's an underlying problem. It's a chronic problem that they have. And when it gets aggravated, they need help. Okay, because asthmatics, they go out and they lead a normal life. But then every once in a while, something happens, a trigger. Let's go down.
So you want to associate asthma with a flare-up or an exacerbation?
Correct, both.
Okay.
Both. So let's say it says definition, a chronic inflammatory obstructive non-contagious disease with varying levels of severity characterized by exacerbations of wheezing and coughing. So the patient who's having an asthma attack, they're wheezing.
Lynette Shockney, Lynette Shockey, or one other.
Pardon me 1 second. Can I call you back? I'm in a Zoom meeting. Thanks. Bye. Wheezing and coughing. Okay. Look at number 2. Episodes occur when the patient is exposed to a specific trigger. Something caused the patient's asthmatic condition to trigger, such as dust, grass, pollen, smoke, animal dander. These things that would cause the exacerbation to happen. Number 3, these are the kind of things that if you had an asthmatic, having an asthmatic episode in front of you, an exacerbation of their condition, they'll have shortness of breath, right? And they might not say shortness of breath. They could use a word like dyspnea. They could say the patient has tightness, right? They're breathing like pursed lip breathing. They could describe the appearance of the chest, and they might say the patient has an increased AP diameter during the episode. Why? They're trapping air. They can't exhale as well. Respiratory pattern. They're using their accessory muscles. They're having retractions. What's happening there? Well, the patient's having retractions. They're working harder to breathe. They have an increased work of breathing. Why? Because of their asthmatic condition. Diagnostic chest percussion. That's when they take the hand, you're tapping on the chest, and it says that diagnostic chest percussion reveals hyperresonant tympanic notes. What does that mean? Well, hyperresonant tympanic means extra air, more than normal air. Breath sounds for the asthmatic during an asthmatic episode says that they have diffuse wheezing, diminished breath sounds, and prolonged expiration. Says the patient's physical appearance is that they are what? They're diaphoretic. They're sweating. Why are they sweating? Well, they're working so hard. They have an increased work of breathing, right? They're having retractions. All of this is because of due to what? Their asthmatic episode that's been flared up, this chronic asthmatic condition that was triggered by something like dust, grass, pollen, smoke, animal dander, exercise induced asthma, anything that causes the airway to be triggered with this inflammatory situation. And then vital signs. The patient's going to be tachycardic. Why? They're hypoxemic. Why? Because they're having an exacerbation of their asthma. They have hypoxemia, and the body's natural response is the heart rate goes up when the patient has hypoxemia. They're tachypnic. Why? Because they're not able to breathe. They're not able to oxygenate. They can have pulsus paradoxus during very severe episodes. And that's due to all the air trapping. Now, number 3, A through G, those are the kind of things that you could see in a question. The MBRC would write a question, and I'm going to give you an example right off the top of my head. You got this 13-year-old boy who is mowing grass in his backyard. He stopped halfway and he started to cough. His mom, looking at him, didn't like the way he looked. What do you think's going on? He was cutting grass. That should have been the first trigger. Nothing else would be talking about. Why would they say he's cutting grass? They're trying to give you the help you identify. Can you pick up that that is an asthmatic trigger? Or little Betty visited her Aunt Sue, who has 12 cats, and all of a sudden she starts to wheeze. Well, what do you should be thinking? Pet dander, right? You need to be thinking. But if you didn't know number 2 up there, those triggers, you're lost. But then they're going to give you some of this. They're never going to give you everything, but they're going to give you enough for you to make a leap saying, this patient is having an asthma attack. And I would know that by, they're going to give me that they're hypoxemic. They're going to tell me about their color. They're going to tell me about their chest. They're going to tell me about breath sounds, bilateral wheezing. When they've done that, I have almost enough information to make this jump. You look at number 4. If they gave you a chest x-ray for the asthmatic during the episode, acute episode, what do we have? Increased AP diameter. Their chest is larger than it needs to be. Why? They're air trapping, right? They're air trapping. Translucent dark fields. Why? It's just a bunch of air. Air shows up as dark inside the lungs, right? They have depressed or flattened diaphragms. Why? Because they're air trapping. When air gets trapped inside the lungs because the airway itself is closing off, then what ends up happening is the air is pushing out against the thorax and down against the diaphragms. Both sides, both in right and left hemidiaphragms. So I'm looking at that. ABGs. If you went ahead and did an ABG on a patient who was in the middle of an asthmatic episode, what would you find? Let's not look at the answer yet. Let's go back up. It said that the patient would be tachycardic. They would be tachypnic, right? I already know you know what a normal ABG is. pH 735 to 745, 35 to 45 for CO2, PaO2 80 to 100, bicarb 22 to 26. And that's how you have to be able to know this stuff. Now you know that, but now they're saying the patient is what? They're breathing really fast. When a patient breathes really fast, what are they blowing off?
CO2.
So then that normal CO2, 35 to 45, you're going to see it drop. When it gets below 35, what are you going to say? Well, the patient is hyperventilating. When their CO2 gets low, what happens to pH? It goes up. So now I know that the pH is going up because the patient is blowing off the CO2. Well, why are they breathing fast? Because they're hypoxemic. So I would expect their P little AO2 to be less than 80. Now I look at this arterial blood gases. It says initially the patient will have acute alveolar hyperventilation with hypoxemia. It makes sense. They're breathing fast. They're blowing off the CO2. And I know the asthmatic condition is causing them not to oxygenate because they can't get their air in. So the patient just breathes faster. That all makes sense. But then it says the patient may develop hypercarbia in status asthmaticus. Hypercarbia, increased levels of CO2. Why? If you initially did the blood gas during the beginning of an asthmatic episode, I want you to imagine this patient's airway is tightening off. All right. So they're breathing faster and faster and faster because they're hypoxemic. They need oxygen. And every time they breathe faster, CO2 is going out faster, pH is going up, CO2 is coming down, but the patient can't get the oxygen in. And they're working harder and harder and harder, right? Retractions, using accessory muscles. They're working harder. So when they work harder, just think about when you guys are in the gym. When you're working out and you're working harder, what do? You sweat. You become diaphoretic. Okay? But you do that on purpose. The patient had some kind of a trigger. Maybe it was grass, maybe it was pet dander, but then they started to wheeze. Then the airway started to close off more. They started to work harder to breathe. The respiratory rate went up because they were hypoxemic. And then it just kept on going. So initially, you see this acute alveolar hyperventilation with hypoxemia. pH high, CO2 low, PO2 low, bicarb said the same, because that's something that would have to change over a longer period of time. You understand that. You did the blood gas, it matched that. But say an hour later, you went ahead, you looked at the patient. Oh, wow, they're looking like they're doing a little bit better. They're not working as hard to breathe. You do another blood gas. You might find that pH in the normal range. You might see that CO2 where it was really low start to come back up into the normal range, but they're still hypoxemic. Some people could misunderstand that and think the patient's getting better when actually they're about to die. Think about this. If I take you to the gym and we're doing bench pressing, and you do the first set, you do the second set, and we're going back and forth, benching. And then all of a sudden, half hour later, we keep on benching. What happens eventually? You get tired. That's what's happening to the patient. You slow down. So when the patient starts to slow down, they're not breathing as fast. When they're not breathing as fast, are they blowing off as much CO2? No. So the CO2 starts to climb. When the CO2 starts to climb, what happens to the pH? It starts to come back down into the normal level. So if you did that blood gas at that time, you would sit there and say, oh my gosh, patient's doing better. When really, they're about to stop breathing. They're pooping out. Does that make sense?
Mm-hmm.
Yeah.
All right. So you have to be thinking about that. And we won't even get into the pulmonary function stuff yet. Okay. Let's go down to number 5. As soon as you identify the patient is struggling, they're having this hypoxemic asthmatic status asthmaticus episode, what's the first thing you got to give them?
Oxygen.
Oxygen. You got to give them the right level of oxygen. Then what are you going to give them? Aerosol therapy with SABA, anticholinergic. So you're going to give them like a Duaneb, something with albuterol and atrovent. Think about this. In the real hospital, that patient comes into the emergency room, that patient can really die. They really can, but not on the MBRC exam. They can't. All right. In the real world, patients really die. So many times, these steps that we're talking about that we would take, we don't have time to dilly-dally. We don't have time to waste. We got to get right to the point. And what we would do in the real life situation, we're going to give them oxygen. We're going to give them the Duanebs. We're going to get them on corticosteroids. We're going to be throwing all of this at them immediately. Why? They could die. But in the real world, on the MBRC exam, they're not going to. The MBRC rules. You only have one patient. When you're dealing with one Question, you only have that patient to deal with. In the real world, you saw clinic, your preceptors, maybe you even work in the hospital. That's you got this work list. You got calls for code blue, this and that. You've got all these other responsibilities. And so you need to be thinking in terms of, I got to get this done, and then I need to get on to the other patient. So you change the workflow a little bit because you have to be ready for anything. At the MBRC, you only have one patient. You got all the time in the world. Your patients never die. Physicians aren't in the building, and you need to be able to take control. So knowing your patient will not die, the very first thing you're going to do is put them on oxygen. Why? They're hypoxemic. Well, if they're hypoxemic, why? Because they're having the asthma episode, right? Some trigger caused their asthma to exacerbate, get worse, which causes them to wheeze, which causes them to breathe harder. And when they breathe harder or have an increased work of breathing due to their asthmatic condition, then the CO2 goes down, P little AO2 is going down. You've got to give them oxygen first here, okay? Then what are you going to do here? Next, I'm going to give them the SABA, the short-acting beta agonist. I'm going to give them that, and you're going to have the anticholinergic parasympatholytic drug, right? At the MBRC, you're going to give them a bronchodilator. And then you're going to give them another bronchodilator. And then you're going to go ahead and give them a bronchodilator with the atrovent. And then if that doesn't work, you're going to go ahead and give them the continuous bronchodilator treatment. In the real world, they ain't doing that. They're putting it all together and giving to the patient immediately because the patient really can die, but you have time. You go down, corticosteroids, got to get those, the anti-inflammatories in there. Close monitoring, right? And then if you look at E, it says intubation and mechanical ventilation, event failure or respiratory arrest occurs. So you never want to put an ET tube in an asthmatic. Almost never. If you can avoid it, you want to avoid it. Why? Think about this. Something got into the patient's airway, some trigger that caused the asthmatic condition to flare up. An ET tube is another trigger. All right. It's a foreign body. As soon as you put that ET tube into the patient's airway, the asthmatic patient's airway, it's going to attack it. It's going to make the condition worse. You know that, but you're at this situation right now. Okay, I don't want to do this to Richard. I don't want to do this to Ruben. But if I don't put this airway in, they die. Well, I really don't want to have them have the asthma condition get worse. Well, which is worse? The asthma condition gets worse or they die. I think dying trumps that. I'm going to go ahead, give them a last-ditch effort and try to help them. All right, so you put the airway in as a last-ditch effort before the airway completely closes off and you can't get a tube in. That can happen. So once you've done that, you can look at F and you can consider other types of therapies, other additional. Adjunct means additional therapies. Like an adjunct faculty, you had full-time people who were in your respiratory program, full-time faculty, part-time faculty, and then you might have had some per diem, some adjunct faculty who came in and kind of help, right? Those are just extra. And what extra therapies could you consider? Heliox.
Yeah. Mm-hmm.
Mag sulfate, subcutaneous epinephrine. You know, these are some additional therapies that you might want to consider maybe before you intubate, maybe after you intubate, because you know you're losing your patient. Does that make sense?
Mm-hmm.
Yeah.
But these are the therapies. Number 5, A through F, that is the order and the treatments that you're going to choose for the patient. What's the first drug you always give your patient? Almost always.
Oxygen.
Oxygen first. Now, if I did your seminar, when I did it, I would have told you if the patient is showing retractions using accessory muscles, muscles that they don't normally use, I would have made you write a note in your book that said, put them on O2. Put them on O2. And I can tell you exactly where that would have been. Don't lose that page, but turn to A15 in your study guide. A14 and 15. Okay. A14 and 15. This is all about breathing. So understanding what normal breathing is and then understanding what abnormal breathing is going to be important, because now we've just thought about this asthmatic, right?
Mm-hmm.
And this asthmatic, if they're normally breathing you and I, right? And that asthmatic, when their condition is not flared up, if you look at number 10, A, they have symmetrical. We all have symmetrical chest movement. What is that? Where the chest is moving at equal distances at the same time, up and down easily. You know, in bad situations, when you have some type of problem, some kind of pathology, it can end up with unequal or asymmetrical chest movement. Normal is symmetrical, but if they said that there was asymmetrical chest movement, or they said the right side was moving more than the left side, that should be a bell going ding, 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 ding. Richard and Ruben both say, you know what? This is abnormal. This isn't right because it should be symmetrical. What could be wrong? And you can look at the under C, post lung lung resection, atelectasis, pneumothorax, flail chest. Maybe you intubated the patient at tubes too far, but you picked up that that's abnormal. And this is all related to breathing. Now I go to number 11, breathing patterns. These are all these terms the MBRC uses. Is it fair? No. Normal breathing is normal breathing. Why can't they just say freaking normal breathing? They don't say it. And you know what? They didn't make you go to respiratory school. They just make the test, and you have to know what to do so that you can pass their test. Once you pass their test, you're not going to go around using these terms. Some of them you will, most of them you might not. But you'll say normal breathing. Well, look at A, eupnea, normal respiratory rate, depth, and rhythm. Really, you just needed to know that term. Eupnea means normal. And what does that mean? 12 to 20 breaths per minute. You had to know that. If you didn't know 12 to 20 was normal, you're lost. If it's less than 12, they're bradyapnea. They're breathing too low. If they're greater than 20, they got tachypnea. If I come down that, that's B and C. All right. Oligopenia is another term the MBRC uses. Is it fair? No, but it's just the way it is. Okay. So what could cause a patient to be tachypnea, to have tachypnea? Look at number 1, right after cause. First thing is hypoxia. So when you see a patient whose respiratory rate is really high, first thing I'm thinking is a lack of oxygen. You guys follow where I'm saying? I always associate that, right? Could be they also are sick. They have a fever. They're in pain, or they might have a central nervous system problem. Bradyapnea, all right, or oligopenia. This is when the rate's less than 12. What causes that? When you fall asleep, your respiratory rate drops. When I fall asleep, our respiratory rate drops. All right, that's normal. But you could be on some drugs. You could have drank way too much. You could have a metabolic disorder. These are some of the conditions that could cause your respiratory rate to drop too much. Apnea, we all know that means you stopped breathing. If you put a bracket around E, F, and G, hyperpnea, Cheyne-Stokes, or Kine-Stokes, I call it Cheyne-Stokes, and BIOTS or BIOTS, those are all related to the central nervous system. You need to know what they are, because the MBRC could give you a question where they describe the respiratory pattern. They don't use the term, they describe the rest. They say, upon doing the bedside assessment, you looked at the respirations, and there's an increased respiratory rate, increased depth, and irregular rhythm. Well, what do we got going on here? We got a metabolic disorder, or we have a central nervous system problem. Or they could say, upon doing the bedside assessment, the respiratory therapist then identifies a gradually increasing and then decreasing rate and depth in the cycle, lasting anywhere from around 65 to 70 seconds. They're giving you it's in the range. They're not telling you 30. It's not textbook, but it's inside that range. And they have periods of apnea that are lasting 20 to 25 seconds. Well, guess what? That is Cheyne-Stokes. What could cause that? Well, let me check. They said the guy was in an automobile accident. Well, that could mean they have an increased intracranial pressure. They have an increased ICP. That could be the problem. Could be brain stem injury. Could be a drug overdose. You know, the patient was found unconscious at a party. Could be that too much ingestion of some type of drug or alcohol. Come down to biots. Could be increased respiratory rate, death with irregular patterns of apnea. Irregular is different than when it was up there for Cheyne-Stokes, where it just said periods of apnea. And this was clearly a CNS problem. Now, an area where you definitely will see something on the test is with Kussmaul's breathing. Kussmaul's breathing, right? As soon as they say Kussmaul's breathing, or they said the patient had an increased respiratory rate, 25 times a minute, increased depth, irregular rhythm, and their breathing sounds were very labored, I'm thinking diabetic ketoacidosis, DKA. DKA. Hypoxemia can cause that, but when I'm looking at that, typically the big one is diabetic ketoacidosis. Now, apneutic, probably not. I haven't really seen any reference to it. You can review that, but hypopnea, this is shallow or slow breathing. This is associated with sleep studies. Okay. Now, you needed to know the breathing patterns. Why? Did you realize that I could give you the MBRC could give you a question and they describe the respirations? They're going to give you a rate. And so you have to, is that normal? Is that abnormal? What's wrong? What do I do? When do I stop? If the respiratory rate's normal, I'm good to go when it comes to that, right? What happens if their heart rate, they give you a heart rate? Well, if it's increased, right, then I know that they have what? Tachycardia. I'm thinking they have some kind of hypoxemia. If they're tachypnic, they're breathing fast. Why? I'm thinking they have some problem with oxygenation again. I'm going down this list and I'm using those words to describe a condition, how the patient would present, and the MBRC is going to give that to you in a word question format. You have to identify, is it normal or is it abnormal? And when it's abnormal, you have to then decide, okay, what system is it affecting? Ventilation, oxygenation, circulation, perfusion. Look at the top of A15. Number 12, accessory muscle activity. B are all the normal muscles of ventilation. Be good to be familiar what's normal, right? The diaphragm, external intercostals, and exhalation should be normal and passive. You and I, we breathe in, and then we just blow out. It's just passive. Effort to breathe in, easy to blow out because it's all passive. It's all with elastic recoil of the chest. But I would put a star next to C because those are the accessory muscles of ventilation. If they describe the patient using the number 1 and number 2, internal intercostal, scalene, sternocleidomastoid, pectoralis major, or any of the abdominal muscles, that means it's serious. Now, I want you to put a note right next to C1 and 2. Give O2. Give oxygen. Why? Well, the patient has an increased work of breathing. They're using accessory muscles. They're working hard to breathe. But Alan, you said ventilation, oxygenation, circulation, and perfusion. Ventilation's first. You're right. And I'm going to let you know, ventilation and oxygenation is right here. It's right up, right up to ventilation. There's not that much of a difference. All right. But if I had to choose between one or the other to start therapy, I'm going to go with ventilation. But oxygenation is an unbelievably close number 2. Right. I'm trying to get you to play a play. Either one of you guys play a sport ever?
Oh yeah.
What'd you play?
Basketball.
Basketball? Richard?
Rugby, football, basketball,
Okay.
baseball.
I was football. I didn't get a chance to play rugby, my college, but I played football. I was a running back. Okay. And I can tell you, my job was to know the playbook. My job was to be in condition and be prepared. And my job when the play was called was to hit the hole, to hit the block, to do what I was supposed to do. That was it. Did it always work? No. But if everybody did their job, we had a better chance of being successful. Now, it really depended on the other team and how everybody did their job and if they were matched up right. But again, if I ran Wildcat every single time, that's not, no one's prepared for that. Right? So I'm telling you the same thing here. You've got to run the play. You've got to know what we're talking about and then execute it. Now, if the patient has any accessory muscle use like here, these accessory muscles of ventilation, give them O2. But what is the play always? It's going to be hit the hole. If you're told to do that, hit the hole. Ventilation, oxygenation, circulation, perfusion. But all of a sudden, your guard or your tackle falls. I'm supposed to hit the hole, and that's all piled up. I'm going to go ahead and do a little bit of an audible. I'm going to go and I'm going to hit an outs, right? I mean, seriously.
Yeah, you're right. Yeah.
So right now, this would be that all of the linemen all fell on top of each other, and I'm supposed to hit that hole. Well, that'd be stupid if I didn't go ahead and go lateral, right? And then I hit the next hole. So when you see intercostal muscles and abdominal muscles being used, you give O2. You got to start them on O2 first, and then we'll worry about the ventilation problem. Okay? The rest of this stuff here talks about muscle condition, hypertrophy, and atrophy, increased size or decreased size in the muscles, retractions, right? Intercostal sternal retractions, that's what that is talking about. A, look at the end of B. Highlight, it's a severe airway obstruction and or respiratory distress. This sounds like the asthmatic who now has retractions. Do you follow where I'm going? Right? The patient has wheezing, they have an increased respiratory rate, they have retractions, they're using their accessory muscles to breathe. Based on what I just read on this page A15, I know they have retractions. I know they're using accessory muscles. So I'd like to do ventilation first, but what do I got to do first? I got to put them on oxygen first and then take care of the airway. Does that follow?
Yep.
Okay. Then you can come down, nasal flaring, that's for infants. Look at 16, character of the cough. Typically is strong, moderate, or weak, productive or non-productive. You can read through the rest of the stuff, but A and B is really where the meat and potatoes are. Everybody following why I just did this? This is all based on breathing and chest. Okay? If you both know A14 and A15 really super well, meaning you don't just write a note card out and memorize it. Both of you guys, aren't you tired of memorizing crap and it not making sense? Your brain, you're like, I can't memorize anymore. I can't make heads or tails out of all this crap that's jumbled around my head. That's where pathology comes in. That's where these little things like ventilation, oxygenation, circulation, perfusion. That's where Allen's 3 Ws. Identify what's wrong. then decide what are you going to do, and then when are you going to stop. Now, A14 and 15, you can say that that was important, but let's go back to J5. So we're going to read through this again. I look at the definition. It's a chronic. What does chronic mean? If I looked in the patient's chart, they probably have other instances where they've had problems with this condition, a chronic problem. Okay. Acute means sudden onset. Chronic means ongoing.
Ongoing, yeah.
Okay. So this chronic, ongoing, inflammatory, obstructive, non-contagious. So even though they're coughing up a thing, you don't have to worry about catching something from them because this is not that. It's just their airway with varying levels of severity, mild, moderate, severe, characterized by flare-ups, exacerbations of what? Wheezing and coughing. Says number 2 is talking about the things the patient could be exposed to, triggers, right? Dust, grass, pollen, smoke, animal dander, exercise. You could write that down. Exercised asthma. I actually have that now. I start to exercise in the very beginning. I cough a little bit and then I work right through it. But I do have a little bit of exercise-induced asthma. If the MBRC was giving you when they're giving you a question and they want you to be able to identify this is an asthmatic having an asthmatic exacerbation, a flare-up, they can give you some of number 3. They can say the patient is complaining of chest tightness. When doing the bedside assessment, you identify the patient has an increased AP diameter. They're using their accessory muscles. Uh-oh. As soon as I saw they're using accessory muscles, what did we say? Give them
oxygen.
Oxygen. Go down to number 5A. What am I doing? First drug.
Oxygen therapy.
Oxygen. Okay. If I did diagnostic chest percussion, I'm going to realize they have what? It's going to be hyperresident. Well, what does hyperresident mean? Hold on. Don't lose that page. Turn to A25. When I'm looking at A25, these are a lot of radiologic terms that they use. Okay. But for the x-ray, don't lose that page. Now turn to page A18. This is that diagnostic chest percussion. We're not at the top of A18. We're not doing CPT. We're not pounding on the patient's chest. We're tapping to hear a sound. If it's resonant, it's normal. Flat and dull means some kind of consolidation or fluid. But then you have tympanic and hyperresident at the bottom. That means air-filled, more air. All right? Hyperresonant, booming sound that can be heard in the area of the lung, whether it's a pneumothorax, emphysema, or could be asthma during the acute exacerbation of the asthmatic condition. Okay? They can also describe it as drum-like, and that's tympanic. Tympanic and hyperresident mean a lot of air
Extra
is
air.
being trapped. Flat and dull means less air than normal, and resident means normal. Give you an example. You ever heard Goldilocks and the Three Bears? That story as a kid. Remember, Goldilocks breaks into some cabin in the woods. She was out there by herself. Why the heck she was, I have no clue. But she broke into somebody's home, decided to eat their food, and then go to bed like an idiot. But she gets in the first bed, and she says, what? Too soft. Next one, too hard. Last one, just right. Too little air, flat and dull. Too much air, hyperresident, tympanic. Just right, resident. Does that make sense? Okay, perfect. When you come down on page A18, they can talk about vesicular. Breath sounds that are vesicular. patient has vesicular breath sounds. Well, who the hell in their right mind says vesicular at the hospital? Nobody. They say the patient has normal breath sounds, NS, NSBS. But the MBRC can call it vesicular. Why? Because they can, right? So you just have to know vesicular means
Normal.
normal. Right. So bronchial breath sounds. Bronchial breath sounds can be normal. It depends on where are you hearing them, though. If you're hearing them on the lung periphery, this isn't normal. This means they have some kind of consolidation. Okay? Then you have increase, decrease, unequal, absent breath sounds. I'm sure you guys are familiar with egophony, where the patient says E and it sounds like A. That indicates consolidation. And bronchophony, or whispered pectoriloquy, they talk about the increased intensity of the spoken word. If that occurs, then you're also thinking consolidation or pneumonia. If there's a decrease in the bronchophony or whispered pectoriloquy, I would think it's not a consolidation, it's air trapping. Increase in spoken word, consolidation. Decrease, I'm thinking air trapping. Does that make sense?
Yep.
You go to the next page, A19, abnormal breath sounds, adventitious. Well, what do we talk? We never say adventitious breath sounds. The MBRC does that. We say a patient's got crackles or rhonchi, right? We don't say that, but the MBRC will say patient has adventitious breath sounds, or they could say the patient has non-adventitious breath sounds. Well, what's non-adventitious breath sounds? That's vesicular or normal breath sounds. They play around with the words, and it's unfair because we all come from different areas where we might not use those words all the time. But if you want to pass the test, you got to know the words. When I look at crackles, crackles mean what? Fluid where it's not supposed to be. I like 1, 2, and 3 because it talks about coarse crackles, medium crackles, and fine crackles. They're all crackles. They all have fluid where they're not supposed to be. But based on that adjective in the beginning, coarse, medium, or fine, it tells me where it is in the airway. Coarse crackles means it's in the large airway. Have them cough or suction. If it's the medium crackles, it's in the medium airway. Okay? What are you going to do? Bronchial hygiene therapy. And fine crackles are going to be at the alveolar level. And what is that associated with? CHF, pulmonary edema. There's the therapy you would recommend. If I look at wheezing, B, look at number 1, most commonly caused by bronchospasms. What would you give to reverse this wheezing? Bronchodilator if there's diffuse bilateral wheezing. If there's unilateral wheezing, it's a foreign body obstruction. And that's where you would recommend a bronchoscopy. So I'm going to tell you this. When I have bilateral wheezing, I give them a bronchodilator. When I have unilateral wheezing, I give them a bronchoscope. Bilateral wheezing, bronchodilator. Unilateral, bronchoscope. Okay? Stridor, high-pitched crowing noise. Well, it depends if they talk about it. Where is the stridor coming from? Supraglottic, subglottic? What was the cause? Some kind of foreign body aspiration. You'll see number 2, the treatment, right? Topical decongestant for supraglottic airway obstruction. Topical decongestant. What the heck is that? That's a racemic epi. I know a racemic epi treatment. I understand that. Alpha vasoconstriction, bring the vessels in, decreasing the swelling. Why are they calling it a topical decongestant? I can't tell you. I just know that they can do it. All right. That's for swelling and edema. Suctioning or bronchoscopy for something that's in the airway. And then if you have, right, you have intubation for severe swelling and epiglottitis. The baby has croup, you can handle it. If the child has epiglottitis, you can't. You've got to go ahead and treat this aggressively, where you would have a anesthesiologist, a pediatric anesthesiologist intubate the child, not you. So you had to know this stuff. So now A18 and A19 are kind of lending itself to this asthma page. You guys follow. Go to A25. two big boxes. You should be familiar that if it's in a box in our book, you've got to know it. You've got to know this in the book. All right. So radiolucent, radiodense, infiltrate, consolidation, hyperlucency, vascular markings, diffuse, and opaque. You've got to know those terms. Okay. Because you want to associate those terms with a diagnosis. Why is that helpful? Because it helps me do the first W, identify what's wrong. Does that make sense? So they could say, upon looking at the x-ray, the radiologist says there's a dark pattern of air. Well, that's normal. That's radiolucent. That's normal. Or they could say, upon looking at the x-ray, it was radiolucent. You'd have to both know both of them to say that's normal for the lungs. If there was radiodense opacities, well, that's normal for bones and organs. You had to know which is which. Infiltrates, anything that has an ill-defined radiodensity. There's some kind of weird, it's not a bone, it's not a rib, it's not a spinal process. It's some other weird shaped density in the lung. Well, that's abnormal, and I'm thinking that's probably atelectasis. Consolidation, solid white areas. This is consistent. So then I'm looking at not just the little patchy problems, I'm looking at pneumonia or a pleural effusion. Pneumonia is inside the lung, pleural effusion is outside the lung. Hyperlucency, extrapulmonary air. Where would I see that? COPD, asthma attack, and pneumothorax. Vascular markings. These are normal. You and I, if we had an x-ray done on our lungs, we'd all have normal vascular markings. This is the lymphatics, vessels, and lung tissue. But if they say they had increased vascular markings, that's CHF. And if they had absent vascular markings, that means they have a pneumothorax. And opaque would mean fluid or solid. That's consolidation. These are terms that you have to associate with a diagnosis. And you have to know the terms and you have to know the description. This would be a great page to make note cards, flashcards yourself. Now, if I come down to the bottom, on the left-hand side, you will see 7 rows. Those are 7 different pathologies. And I'm going to tell you this, you're likely to see, and you both have taken the test, you're likely to have seen 5 out of 7 of those.
Mm-hmm.
All right, at least, if not all of them sometimes, right? But at least 5. Now, I want you to look at the terminology column. When I look at the very first one, fluffy infiltrates, butterfly, and bat wing, you guys see that?
Mm-hmm.
Go down below that. Where else do you see butterfly and bat wing?
Nowhere.
So
Nowhere.
the MBRC says upon looking at the x-ray, it shows butterfly pattern or a bat wing pattern. In your head, you should be going ding, 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 ding. What do I have? Pulmonary edema. How do I treat it? Diuretics, digitalis, digoxin. You've had to identify the first W. What was wrong? Well, a butterfly pattern is not normal. A bat wing pattern is not normal. Fluffy infiltrates is not normal. Well, what is it associated with? Well, that's associated with pulmonary edema. When I look at atelectasis, patchy infiltrates, if I go down, I don't see that anywhere else. If I see plate-like infiltrates or crowded pulmonary vessels, crowded air bronchograms, I don't see that anywhere else, crowded. That again is indicative of what? Atelectasis. How do I treat atelectasis? Lung expansion therapy. So what's wrong? Well, they've got these crowded pulmonary vessels. Well, what does that associate with? Atelectasis. Well, what am I going to do? I'm going to go ahead and give them lung expansion therapy. When do I stop giving them lung expansion therapy? Well, when the atelectasis is gone, when they no longer have crowded pulmonary vessels. Is that making sense?
Mm-hmm.
Yep.
Look at ARDS, only place where I see ground glass, right? Honeycomb pattern, reticular, granular, reticular, only with ARDS. Well, once you identify it's ARDS, how do you treat it? ARDS protocol. No one ever comes to the emergency room. You're not working in the respiratory department. and they say, hey, Richard, go down to the emergency room. There's a new patient, a new start. What's their diagnosis? ARDS. No, ain't going to happen. ARDS can occur. It's not an initial diagnosis. ARDS can be manifested from any other condition that the patient had. Anything else that they were in the hospital for could eventually turn into ARDS. It's a secondary, very dangerous syndrome. I go down to pleural effusion, right? Blunting, obliteration of the costophrenic angle. Basilar infiltrates. This is where I would get confused. These are a lot of frequent words I don't normally use. All right. And if you're like me, this is overload, guys. This is overload. I get it. But here, what I'm trying to, there you go. Perfect, Ruben. So that's what you're doing here. And then once you've identified that that's the problem, then it's a pleural effusion. Well, where is that problem? That problem is outside the lung. It's fluid building up in the pleural space. So when I identify and I confirm that it's a pleural effusion, I would go ahead and get something called a lateral decubitus chest x-ray. I would confirm that it's a pleural effusion. And then how do I treat it? I would do a thoracentesis. I would go ahead and get some of that pleural fluid, send it to the lab, have it identified. If it's straw colored, light colored, I'm thinking it's associated with CHF. But if it's a funky looking color, I'm associating with an exudate. And then I have to send it off to the lab. Why? Because I have to find out what's growing in there so I can go ahead and start them on the right antibiotics and steroids. Now, if you don't do that, that fluid's going to come back. So you're going to have to put a chest tube in. Pneumonia. Another word, AKA, for pneumonia is air bronchogram. You just have to commit that to memory. If they say the patient has an air bronchogram, that's pneumonia. How do I treat pneumonia? Antibiotics, O2. That fourth column is not all inclusive, right? It's just giving you some of the treatment. You'd have to go back in the book in section J and pull the rest up. Pulmonary embolus, only place where you see peripheral wedged shape infiltrate. If they say wedge, I'm thinking PE. How do I treat PEs? I stabilize the patient, I give them O2, I take care of the oxygen ventilation, but I got to do something with the existing clots and the future clots. So existing clots, break them up, heparin. Future clots, I'm going to prevent them with streptokinase, urokinase, and TPA. Tuberculosis, only place where they use the term cavity. And where is this cavity? Normally in the upper lobes. Where else did you see that? Nowhere. This whole page is a must know. If you don't, you're going to be lost. If you know this page, it's going to help you identify the first W, what's wrong. Does that make sense? Okay. The subsequent pages are all on x-rays that you could see on the exam. And you will see probably 1 or 2 x-rays on the exam. All right, when you take it. They no longer just give a written report. They can actually give you an x-ray and expect you to be able to identify from the x-ray what is wrong. Well, that means then, if they can give you an x-ray, you need to know page A21. And you both have taken the test. Did they give you an x-ray? Did they give you a picture to look at?
Yep.
At least one? Yeah,
Yep.
guaranteed.
Yeah.
At least
And if
to
you
the
don't know normal, you're lost. So when I look at that PA view and lateral view, look at 1, 2, 3, and 4 up under B. That's normal. And then when I go down below, talks about the quality of the x-ray. Heads of the clavicles should be level. All right. If you look at C1, proper exposure shows penetration, shows the intervertebral disc spaces through the shadow of the mediastinum. If I flip the next page, A22, what is the trachea? It's the midline part. Well, could the trachea shift from one side to the other? Yeah, it does. Right? It can identify unilateral lung problem, meaning I have problem in one side of the chest, either the left or the right, right? Go to the mediastinum. This is the area where the lungs and heart and lymphatics and blood vessels and major bronchi are found. That could shift too with a pleural effusion. AP diameter, increase with COPD, barrel-chested hyperinflation. Costophrenic angles, obliterated or blunted by pleural effusions. Diaphragm, it's what it's normally shaped as, but it can be flattened with obstructive lung disease. Or it can be flattened during an acute episode of asthma. Okay, we're going to get through this. Vascular markings, blood vessels, lymphatics, lung tissue. That's normal. What does the heart and position look like? You know, go down to number 9, ribs. Look for the normal curve and spacing. If there's crowding, only other place, remember we saw crowding before it meant for atelectasis? Now we got crowding of ribs. What is it related to? Atelectasis. It's the only time they use the term crowding or crowded. So again, when you start learning these hints that are associated with the pathology, you're going to be able to identify what's wrong. Then you're going to be able to go and decide, what am I going to do for the patient? Now, I just went over several pages in section A for you guys. Let's go back to J5. And I know this is going to sound redundant. I'm telling you how I study. I will let you know. My wife, my daughters, my son, I mean, I'm not joking, very intelligent people. They might hear something or read something 1 or 2 times and they're going to remember it. I ain't built that way. I'm just not. I read something 1, 2, 3, 4 times. I think I got it. Step away for just about 5 minutes and I start doubting myself. I've got to repeat. Then I'm done when I think I'm done. No, you're not. Repeat it again. Because what ends up happening for me is something will distract me. Something will distract me, cause me to question my confidence. And even the things that I do know, I'll start to question. What's my name? I can't remember my middle name. You know, just because I lost that sense of confidence. I ain't here to BS. I'm not here to tell you, poor you if you're built like that. Suck it up. That's just the way God made you. That's the way I was made. I know my strength. I'm going to work harder than everybody else. I'm not going to quit. I'm going to use the tools even more efficiently. I'm going to do what I need to do. And if it takes you to read something 20 times, then do it. And I'm telling you, like the pathology. So now this is our 3rd or 4th time I'm going through this. Okay. Asthma. The very beginning, number 1, it's a chronic problem. So once a patient has this condition, they're going to have it for life.
Mm-hmm.
And then occasionally it's going to what? Flare up. And the term that they use in the hospital is what? Exacerbation. And when they have this exacerbation, how is that characterized? How do you know they're having an exacerbation? They're going to have wheezing and coughing. So if they give you a question and the patient's wheezing and coughing, you should be saying in your head, ooh, this could be an asthmatic. I need more information, but this could be an asthmatic. Did they give me any information? Well, they said little Johnny was mowing the grass. That sounds a lot like asthma. Little Susie was visiting her aunt with 12 cats. You know, Ruben was out playing basketball, and all of a sudden he had this coughing and wheezing. Well, that could be exercise-induced asthma. Mm-hmm. You guys follow, right? Yeah. But you had to know that those are the kind of conditions that cause wheezing and coughing, right? Number 2 is the episodes occur when the patient's exposed to a trigger. We've already talked about that. Patient assessment. Patients complaining of chest tightness. Well, now I'm thinking with that plus the coughing and wheezing, it's more indicative of being what? Asthma. Mm-hmm. Increased AP diameter during the episode. That's key because For the COPD patient, it's always. They always have an increased AP diameter because they have the chronic obstructive pulmonary disease always, where the asthmatic only has the chronic obstructive disease during the acute episode.
Yeah.
Okay. The respiratory pattern, they describe the patient of using their accessory muscles and they have retractions. Ding, 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 ding. What did Alan say? When they're having retractions and using accessory muscles, this is very serious. What do I need to put them on?
Oxygen.
Oxygen, right? Diagnostic chest percussion. Now I remember this is hyperresonant tympanic note, right? That means there's too much
Air.
Why? Because they're having an exacerbation of air trapping caused by their asthmatic condition, which is chronic. Breath sounds, diffuse, wheezing, diminished breath sounds, prolonged expiration. Why? Because they're having an exacerbation of their asthmatic condition, causing their airway to start to close off. They breathe in faster, they're trapping the air out, and it takes them longer to try to get that air out because the airway is constricted. Physical appearance, they're diaphoretic. Why? They have an increased work of breathing. Why? Well, they're using their accessory muscles. That's why they're sweating. Why? Well, they're doing it because they have an increased work of breathing due to their airway closing off. Well, what's causing that? Well, something triggered the patient's chronic asthmatic condition to cause them to have this exacerbation of wheezing and coughing. I come down. You say, the question says, what else would you like to help diagnose this patient's problem? You do a chest x-ray and the patient's in the episode. Well, what are you going to see? During the asthmatic episode, I'm going to see an increase in AP diameter, both sides. Both sides, because the asthmatic condition is both sides. If it was one side or the other, I'm thinking not asthma, I'm thinking foreign body obstruction. You guys follow? So both sides. Translucent dark. Why? They're trapping air. That's why. Depressed or flattened, not one diaphragm, both diaphragms. Okay. If it was foreign body obstruction, it would be one side wheezing, one side trapping air. One diaphragm can be flattened and the other one has the hemidiaphragm dome shape.
Or what they like
Does
to
that make
say,
sense?
unilateral.
Of course. Vital signs, they're tachycardic and tachypnic. Why are they tachycardic? Well, because of this exacerbation of their problem in their lungs, they're hypoxemic, right? So their heart rate goes up. Tachypnic, why? Because they're hypoxemic. Why are they breathing faster? Because they're hypoxemic. They're trying to get more oxygen in. You're going through all this stuff here. ABGs, initially acute alveolar hyperventilation. They're blowing the CO2 off, causing the pH to be high. So I have an acute respiratory alkalosis with hypoxemia. If they gave it to you as a interpretation, well, why do they have acute respiratory alkalosis? Well, they're breathing fast. Why? Because they're hypoxemic. I saw that their P little AO2 was less than 80. All right, why are they doing that? Because their airway is closing off. When their airway is closing off, it's making them have to breathe faster. Pulmonary function testing. If you actually did that, a patient with asthma has problems with flows. Patients who have asthma have problems with flows. Okay. Patients who have obstructive pulmonary disease, they have problems with flows. Restrictive lung diseases have problems with volumes. This is not a patient who has a problem with volume. This is a patient who has problems with flows. So you would have to go back to, and we'll do that in a moment, you'd have to go back to the PFT stuff and be able to identify what spirometry measurements are indicative for identifying flow problems, and then what measurements in spirometry help me identify volume problems that would lead to a restrictive disorder. Well, You went through all of this. The patient's tachypnic, tachycardic, using accessory muscles. They're diaphoretic. You're going through this. They got bilateral wheezing. They have SATs of 89%. What do you want to do first? What's first off? What's wrong? They have an acute exacerbation of their asthmatic condition. What's the first thing you're going to do? Well, according to what we said, because of the retractions and stuff, I got to get them on O2. Then I give them aerosol therapy, corticosteroids, close monitoring, intubate if I have to. Consider adjunct therapies like Heliox, mag sulfate, and subcutaneous epinephrine. Heliox, that seems like a really strange mixture of gas to breathe, right? What are you breathing right now? Room air.
Room air.
All right, 79% nitrogen, 21% oxygen.
Yeah.
Well, if I was to go ahead and put them on Heliox, I would just get rid of the nitrogen, that's 79 point whatever percent, 79% nitrogen, and replace it with helium.
Helium, which is lighter.
Lighter, right? Easily maneuvers around obstructions, making it easier to get the oxygen where?
Into the patient.
Yeah, and what was the patient's problem? Why were they tachypnic and tachycardic? They didn't have enough oxygen. So I gave them Heliox to help improve the work of breathing and their oxygenation. If I can get the gas past their airway through this, past this inflammation and obstruction, it's going to decrease their work of breathing. So if they decrease their work of breathing, their respiratory rate's going to come down. Right? CO2 will get back into the normal range. O2 now is getting a chance to get to the alveolar level and cross into the bloodstream. All of this because you understand Heliox now. Now, if I come down, long-term control. During a question, all right, guys, during the question, I'm not even worried about long-term control because right now this is the acute problem. I've got to take care of the acute problem. But if there was another question that talks about, well, what would you do for the patient to help them live with this asthmatic condition? Well, that would be number 6. Help them identify those asthma triggers and eliminate them, right? To avoid or prevent acute attacks in the future. Control meds, these are the LABAs, inhaled corticosteroids, mast cell stabilizers, leukotriene inhibitors. And then highlight C or put a star next to C. The asthma plan needs what? Peak flow monitoring. Flip the page. That is the peak flow plan. Every asthmatic on the test, everywhere you would see an asthmatic, you need to be able to use a peak flow meter and identify those zones. Just in case. Just in case. Did you guys use a peak flow meter in your lab in school? Mm-hmm. You got a peak flow and you set up the zones, green, yellow, and red, right? Green, 80% or better. Whatever they're doing, it's working, leave them alone. Right? So if it was 500 liters per minute was their peak flow, 80% of 500, right, would bring me at 400. So I would put the green at 400. Anything from green 400 and up, leave them alone. They're good to go. At 50% to 79%, that's caution. You got to tell them to stop what they're doing and take their inhalers. Get into a cool place, take their inhalers. Well, what's 50% of 500? 250. So I would put the yellow at 250 and the green is at 80. So it would be less than the green, 80%, but it would be above the yellow one at 50%. If it goes anywhere in the range there, it's 50 to 79%, it's a yellow zone. This is what the patient needs to do. And then the red zone is less than 50%. I would just take that little red indicator and bump it up right next to the yellow one. Because if it's in the red zone, they need to stop what they're doing, take their inhalers, get in a cool place, and call for 911. They need help. They need to get in the hospital and get help. Does that make sense? Mm-hmm. Now, that's the asthmatic. Do you guys feel like you're a little bit better versed on asthma right now? That's what you got to do, dude. Both of you guys, that's what you have to do. But you saw how I walked you through it. Now, if I'm studying, all right, maybe you guys study together. If not, maybe you're talking into your phone and recording yourself. All right. But you want to go through this and you don't want to move on to COPD until you know asthma. I want you to know asthma so well. And you saw how I had to go back to the patient assessment to pick up stuff, right? I went back to patient assessment to identify where the problem was. I want you to know asthma so well that you could teach it to somebody else, right? When somebody asks you a question, what is asthma? You can start talking. It's a chronic condition. Well, what's happening? Well, the patient has this underlying asthmatic type condition that's a chronic problem, but they don't always have problems with it. There's an occasional flare up, and that term they use is an exacerbation. And this flare up is characterized by coughing and wheezing. Well, what caused this exacerbation to happen? Well, there was some kind of a trigger. What were the triggers? And now you list it off. It's like using J5 is your script and you're working your way down. And then the MBRC is going to give you little bits and pieces, not everything, but they're going to give you enough in the question for you to identify what's wrong. And then what do? Number 5. That's how you treat it. Okay. Once you feel comfortable with this, like say we were studying today, I would want you after we're done with our session today to go ahead and study asthma. Make sure you can do what we've talked about. Follow the sequence. I started at the top. I kind of read through the definition, and then I started looking at each of the lines. What does it mean? If I didn't remember something, we went back to patient assessment and we looked for it. And we made sure we were well-versed. We understood what it said. If there's a point where you don't understand even what it's in the study guide, info@ketteringseminars.com, or use your phone and Google it. Google, see what it says. Keep it simple. All right. You don't have to get all your study guides, not your study guides, all your other books out. Because that when you start getting multiple books out, it can get very confusing. Like, what do I use? Who do I use? What resource is right? All right. I'm telling you, this is right. Okay. The majority of people that pass, when they have problems, it's typical in a couple areas. One, they didn't know their pathology, or they didn't know their patient assessment information, what was absolute normal, because then they couldn't identify what was wrong and they couldn't associate it with a pathology or with a troubleshooting situation. They just didn't know how to take care of what do I do? The second W. So you got to first get the foundation set and then you build from there. But you would sit here and you would do this for today. I would tell you typically you don't study for more than 4 hours in the course of a day. Not this 12-hour stuff because you feel like you paid your dues. Next day, you're not even looking at it or whatever. And then if you're like me, if you don't use it, you lose it. All of a sudden, everything seems familiar, but I really don't feel comfortable or confident about anything. And that is not the way to go into the test. So I want you to do this and say tomorrow you're going to study for 4 hours. Right? You did this, you learned this one really well today, and you went back to patient assessment. You saw how long it took us just to go through all that patient assessment stuff. Right? It's been quite a while. Now, I would want you to say, okay, I studied that. I feel pretty good with that. I wish I had more done, but I'm going to take this slowly, right? Because I want to pass it this time, right? How do you eat a pizza? Some people say slice by slice, but you don't. You take it bite by bite, because if you shove the whole slice in your mouth all at one time, the whole slice, you're going to choke. The same thing with information in your head. If you throw your brain too much stuff, your brain chokes. Okay, we need to go ahead, feed it, nourish it the right way. And then I feel good about today. Tomorrow, we're going to go ahead and study COPD. That's the next pathology here. But guess what? when we sit down, first 10 minutes, I'm not sitting there on COPD yet. I'm doing asthma for the first 10 minutes tomorrow. And I'm going to redo, well, what kind of a condition is asthma? Well, asthma is a chronic condition. Well, how would you know the patient's having this chronic condition, this flare-up? Well, they would have an exacerbation or flare-up showing that they're coughing and wheezing, bilaterally wheezing. Oh, okay. Well, what would cause this asthma flare-up? Well, that was the triggers. I would just quickly go through this to make sure I did what? I knew asthma before I introduced any other new stuff. Everybody follow me? So I do that for 10 minutes. If you didn't do it, go 15, 20 minutes on asthma. Why is this important, guys? Because the MBRC is going to give you questions. I'm going to show you the pathology that could be on the exam. And I'm going to show you the ones that I think are the highlights, the most pressing pathologies you've got to know like the back of your hand. When you do that, you can't get asthma questions wrong. You can't get asthma questions wrong because now you know asthma. But what's nice, any questions that were related to the asthma answers, if it's a different pathology, the MBRC can use asthma answers in a choice selection for like COPD or CHF. Well, that's not appropriate for the CHF. That's appropriate for the asthmatic. I know that. So I'm going to prove that to you now. Let's look at J7. We're going to say we studied, you feel really super comfortable and confident. A says the definition, right? Weakening and permanent enlargement of air spaces distal to the terminal bronchioles, all right? Accompanied by hypertrophy of goblet cells and mucus glands, characterized by shortness of breath, dyspnea on exertion, with significant hypoxemia and hypercapnia. All right, that doesn't sound like the asthmatic. This is definitely different. All right, goblet cell, mucus glands, dyspnea on exertion, significant hypoxemia and hypercapnia. Well, that happens with the asthmatic as well. But this is just on any kind of movement by the patient, they become hypoxemic and their CO2 levels are elevated. Why is this happening? Well, for the asthmatic, it was due to being exposed to some kind of a trigger. For this one, this is the weakening and permanent enlargement of their air spaces at the terminal bronchioles. So what's happened? Those are little alveoli, each one has a little neck. All the alveoli are connected to one another with the pores of Kahn and the canals of Lambert. What ends up happening is air gets into these alveoli and it overstretches them. And then those little necks that allow air to go back out, they collapse on itself. And so the air gets trapped. Because of all this air being trapped, you have all these alveoli distally that are being trapped with air. Okay? And then it says it's often accompanied by hypertrophy of goblet cells and mucus clearance. So I'm thinking this patient's going to have a lot of secretions. Okay? I did not hear that about the asthmatic. We didn't talk about having off. We said a cough, but we did not hear anything about secretions. Does that make sense?
Mm-hmm.
All right.
Mhm.
You see, B, these are the other terms that they'll use to describe a COPD patient: chronic vent failure, chronic hypercapnia, increased lung compliance, loss of elastic recoil, chronic CO2 reduction. These are all AKAs. You have to identify, this is my COPD patient. How does somebody get COPD, guys? Typically, they've been exposed to some kind of bad air, smoking, something, maybe they worked in a toll booth, they worked in the coal mine, something that polluted their lungs, and then over time, the lungs couldn't compensate anymore, and their breathing was compromised. So let's look at C. Think about your asthmatic. Okay. General appearance, barrel chested, right? Increased AP diameter. Well, that could be the increased AP diameter could be the asthmatic, but we didn't describe them as barrel chested. Why? Because with the asthmatic, it's only during the episode.
Yep, doing the trigger.
Right? During that period. But for the COPD, it's air trapped upon air trapped on top of that, on top of air trapped on that. Eventually, with all this air trapping, not early stage COPD, but as the COPD progresses, more and more air gets trapped to where the container, it's already pushed the diaphragms down. It's already pushed the rib cage out. It's increased the intercostal spaces. The normal curvature of the ribs is gone. They're straight. And then all of a sudden, there's even more air trapping on top of that. And the cage, the thoracic area says, I can't handle it anymore. Boom. And now you have the barrel chest. Does that make sense?
Yep.
Then you have clubbing. I didn't see clubbing for asthma, right? And, you know, when I see clubbing, I know that's chronic hypoxemia, right? Chronic COPD patient. That's not going out Friday night having a good time. That means that they're having this problem right here. And they have cyanosis. Respiratory pattern, dyspnea, accessory muscle use, and pursed breathing. Well, that could be the asthmatic. They could give that by itself right now, and I can't tell if this is an asthma or a COPD patient just by the respiratory pattern. Breath sounds, diminished aeration with bilateral expiratory wheezing. Again, if they just gave me number 2 and 3 under C, no other information, I'm still leaning towards this could be an asthmatic or this could be a COPD patient. Diagnostic chest percussion, tympanic hyperresonance. Again, this could be either one. But when I get to number 5, congested productive of thick sputum, that's not the asthmatic. That is the COPD patient. So now I'm less thinking asthma, and now I'm thinking COPD. I come to diagnostic testing, chest x-ray, hyperlucency, hyperinflation, increased AP diameter, flattened diaphragm. All right. So that could be an asthmatic too. Very similar to the asthma during the acute episode. Arterial blood gases for the asthmatic. Remember, we said it was what? Acute hyperventilation or alveolar ventilation with hypoxemia. But this is compensated respiratory acidosis. Well, this means the only way it becomes compensated is where the bicarb had to go up. And for that mechanism, a metabolic system to kick in like that, it needed to do what? It needed a lot of time to reach that. All right. It needed time to get to that point. So that's not an asthma. This is going to be a COPD type patient. Pulmonary function testing. These are going to be similar to the asthmatic. We're going to talk about that in a little bit. But then you've identified, all right? You've identified, they said clubbing. They said use of accessory muscle use. Uh-oh. When they said that, what do we have to do immediately? We got to put them on O2. Accessory muscle use. They talked about bilateral wheezing. They talked about tympanic and hyperresonant sounds. But then when they said that the patient had productive thick secretions, I knew that this wasn't the asthmatic. This was going to be the COPD patient. Now, once it was the COPD patient, you've got to treat the COPD patient a little differently than you do the asthmatic. But the first drug is the same. You're going to give them what? Oxygen. For the asthmatic, I'm going to give them 30%, 40%, 50%, 60%, somewhere between 30 and 60%. I'm going to give them that FiO2 to help them. For the COPD patient, if you give them too much oxygen, what happens? O2-induced hypoventilation. Remember, they're breathing by their peripheral chemoreceptors because their hypoxic drive is blunted. So if you give them too much O2, that's going to decrease their breathing, which we don't want. So what kind of O2 am I going to give them? Low flow O2.
20.
Does that make sense? I'm willing to have SATs between 88 to 92. I don't want 88 to 92 for my asthmatic. I want SATs greater than 92%, but that's okay for my COPD patient. Then what am I going to give them? I'm going to give them their bronchodilators, or sabalabas, anticholinergic LAMAs. We're going to look at those. You look at those drugs. That is the drugs that you're giving your patient. Did we give bronchial hygiene to the asthmatic? No, but here we do. Inhaled corticosteroids. Yeah, we need to do that. We did that for the asthmatic. Antibiotics. Well, what if their secretions is this yellow-green color? Well, then I need to go ahead and think about what's growing. I have to do a CNS on the secretions, find out the bug so I can identify the drug that will kill it, right? Referral to smoking cessation program. Well, almost most COPD patients have some kind of history of smoking, either firsthand or secondhand. Okay. And it talks about including nicotine replacement. Here, pulmonary rehab, proper nutrition, fluid intake. We need to help the patient. We did not talk about this for the asthmatic, right? If the patient goes bad, right, they go into ventilatory or respiratory failure. For the asthmatic, what did we do? We intubated them and we put them on a ventilator. What are we looking at here? Don't intubate your COPD patient. Consider non-invasive positive pressure ventilation for those acute exacerbations. Because if we can do that, we can prevent them from possibly having being prolonged intubated. Because a lot of patients, when you start breathing for them, their muscles atrophy very quickly. And a COPD patient, they're almost impossible to wean once you put them on. So we don't want to do that. And then you look here, number 9, refer the patient and family to appropriate education programs. A lot of this stuff is going to be part of the pulmonary rehab or part of the DME, the durable medical equipment company, where they're getting their home O2 and stuff like that. Flip the page. Now this is, you don't have to go into major detail here, okay? But this is gold, right? This is gold, chronic obstructive lung disease. This is the standard that's used to create the plan, the treatment plan, and where patients are, and then what are you going to give to the patient drug-wise. That's D at the very bottom. I would be somewhat familiar with this. I would want you to be more familiar with J7 than J8. Okay? Once you got J7 down really well, then, well, how do I come up with that treatment? How do I find out number 2 under E, aerosolized bronchodilators? How do I do that? How do I know which steroids? That's using GOLD, right? That's using the GOLD initiative for chronic obstructive lung disease. Once I've done this, now I'm doing a comparison. I was going back and forth. Here's asthma, here's COPD. What do they have in common and what's unique? Right? When I see something in the question where they said, I have a 68-year-old patient who smokes 3 packs a day of cigarettes, and they're experiencing hypoxemia and bilateral wheezing, and they're coughing up yellow-green secretions. I'm thinking they're having an exacerbation of their COPD condition. Right? So what do I got to do first? I got to get them on O2. What else am I going to do? I got to help open up their airway. So I'm going to give them the bronchodilators. I'm going to give them the steroids, because both of the obstructive diseases required bronchodilators. Both diseases required steroids. Did you see anything about peak flow monitoring here? No. Okay. That was with the asthmatic. So what I'm trying to do, I'm trying to show you guys I would learn one disease like asthma really well, go back to the patient assessment in the beginning of the book, make sure I'm reviewing that, learn asthma really well. While I'm doing asthma really well, I'm going to go back to the other appendices where they have all the normal values. the things I want to be able to know what is normal. Because once I know what normal is, I can start identifying the abnormal. When I start getting the abnormal and I get this picture that they paint, well, here's the asthmatic picture. This is what that looks like. Here is the COPD picture. That's what that looks like. What does the asthma and COPD pictures have in common? And then what do they have something very unique to themselves? And I would use that as helping me identify what's going on with the patient. When it talked about chest x-ray, well, if I don't remember that, go back to A25 in the study guide and make sure you know the radiology terms so that you can come up with the pathology. Once I feel good with COPD, right? We would have studied asthma yesterday, gone through it. Today we would have done COPD, but first we would have reviewed asthma. Some of it was a repeat. Pardon me. We would have reviewed asthma first, 10, 15 minutes. After that, we'd start COPD. Once I'm going through COPD, it should be triggering in your head. Oh, this is familiar. This is somewhat like asthma. This is it. Oh, but this is unique. This is very different from an asthmatic condition. All right. Kind of like if I said that you were going to give Dornase alpha or Poma enzyme, who would you give that to?
The COPD patient.
Poma enzyme or Dornase alpha. They have an elevated sweat chloride test. Cystic.
Cystic fibrosis. That's right.
Cystic fibrosis. Poma enzyme and DNase or Dornase alpha only, it's a mucolytic only for the cystic fibrosis patient. All right. I'm trying to get you to think about some of these things. When I come over to J9 now, you've studied that, you've done 2 days. Here's the third day. You're sitting down, you're about to study. First 5-10 minutes, you go over asthma. Again, make sure you remembered it. Then after you're done asthma, you also learned COPD. 5-10 minutes for COPD. Make sure you remembered it. If not, go over it. You don't need to jam in more pizza when you got to swallow what you've already got. Okay, so let's get that information in your head. So I do asthma, COPD. When you feel comfortable, now I'm going to come over to CHF, pulmonary edema. All right, let's look at this. A, CHF, abnormal condition reflecting impaired cardiac pumping. I'm going to make this simple. Left ventricle is not working well. It's not contracting well. That's as simple as that. That's the primary pump for the cardiopulmonary system. The left ventricle is not working well. Okay. When the left ventricle doesn't work well, blood slows down. It can be indicative of, look at B, pulmonary edema. When the left ventricle is not squeezing, contracting, and relaxing the appropriate way, what ends up happening is, if you think about your heart anatomy, you got your left ventricle. Right before it is the left atrium. Right before the left atrium is the pulmonary venous system, the lungs. Well, if the left ventricle is not taking all the fluid, the blood coming from the lungs, it just sits in the left ventricle, it's going to back up, causing increased pressures in the left atria, which is going to cause increased pressures in the pulmonary venous system, which is going to cause backup of blood inside the lungs. When we have the backup of that fluid in the lungs, we have the pulmonary edema. So the best way to fix this problem when we're having pulmonary edema is to get the left ventricle to start pumping appropriately again. And so that's what I would do, right? And you can see excessive movement of fluid from the pulmonary vascular system to the extravascular system and air spaces of the lungs alveoli, commonly caused by CHF. What is CHF? The primary pump, the left ventricle, is not contracting and relaxing well. How does the patient appear? General appearance, peripheral pedal edema. Did they say any about that for COPD and asthma? No. This is unique. Did they say diaphoresis? Yeah, anytime you have increased work of breathing, the patient's going to sweat. So them just saying diaphoretic doesn't help me identify the pathology. It just tells me the patient has an increased work of breathing. And they have cyanosis. Well, that could have been for the COPD patients because we talked about that. Respiratory pattern, tachypnea,
Yes.
Yeah.
both of them, all three pathologies. Here's something new, orthopnea. They didn't say that for COPD or asthma. Orthopnea is where the patient only is able to breathe somewhat comfortably in an upright position. Why? When they sit kind of upright instead of laying down, it takes pressure off the heart. When the heart is up, when you're sitting upright, it's all of your belly, all the fluid is not pushing down on the left side of the heart. So it makes the left heart easier to work with whatever it has. But if that patient's laying down, all that extra force against the left ventricle that's already compromised can't work well. So they talk about the patient being orthopnic. So that's important. Paroxysmal nocturnal dyspnea. Well, paroxysmal nocturnal at nighttime. Well, what do patients do at nighttime?
Sleep.
Sleep. And how do you sleep? Typically, you lay down.
Lay
You
down.
might have a grandparent or somebody like that. They sleep in a recliner because it's the only place that they're able to relax and get sleep. What's that? That's a semi-Fowler position because when they're flat, it puts pressure on their heart. So they are able to sleep more comfortably in an elevated position. All right. Going down to breath sounds, crackles and wheezes. Well, wheezes is on all of them. Crackles, a little different. Could be something related to the COPD, depending on how bad that problem is, but that is not a asthma problem. So that would be a key. Pink frothy secretions, ding, 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 ding. I'm sure you know that already. That's going to be dealing with pulmonary edema. Well, why is pulmonary edema being caused? Well, it's caused as a secondary problem to the CHF. And what is CHF? The left ventricle is not working well. Diagnostic chest percussion, flat or dull. Why? Got fluid. If I don't remember that, I turn back to A15, 16, whatever those pages were, and you look at what the diagnostic chest percussion. Remember Goldilocks. Too soft, too hard, just right. Too much air, not enough air, and just the right amount of air. And when it's dull or flat, it's some kind of consolidation or fluid. Well, what do they have? Pulmonary edema. Why? Left ventricle is not working due to why? The CHF. So if I stopped right here, and we identified that the patient's problem was pulmonary edema secondary to CHF, when CHF is exacerbated, what part of the heart is not working?
The left ventricle.
Left ventricle. Give it a drug that will help the left ventricle squeeze and contract better. Digoxin.
Or digitalis or digitalis.
Right, or digitalis. Very good. So now diagnostic testing. Chest x-ray. Bilateral fluffy opacities. Wow, okay. Seems to be, if I go back to 825, I'm going to be able to identify that very quickly. Dilated pulmonary arteries. Left ventricular hypertrophy. Butterfly or bat wing patterns. These are all indicative of
Pulmonary edema.
yeah, secondary to congestive heart failure. ABGs, respiratory alkalosis with hypoxemia. Well, that could be a COPD patient. No, it can't. It has to be just the asthmatic, right? The COPD would have chronic, right? Because they would have an elevated bicarb. This would be more, this respiratory alkalosis with hypoxemia, that could be the acute stages of asthma, but not COPD. So now I can get rid of COPD. It can't be that. So now this is a running of CHF, pulmonary edema, or asthma, but I've already had some of these other things, orthopnea, saying pink frothy secretions. I know this patient has pulmonary edema. Right?
Yeah.
Now you get into some of the other things here. Pulmonary function testing, hemodynamics, increased pulmonary capillary wedge pressure. Well, the left ventricle is on the left side of the heart. So you had three primary hemo measurements, CVP, PAP, and pulmonary capillary wedge pressure. If they have an elevated CVP, it's right heart. Elevated PAP, I'm thinking lung problem. And an elevated pulmonary capillary wedge pressure, I'm thinking left heart.
Yeah, left heart, yeah, wedge.
So this is all, they're giving you more information to identify what's wrong. So I use that to help me identify it. Cardiac enzymes. There's only two, or we're looking at cardiac testing, right? We can do the BNP or the troponin levels. Well, I'm not thinking they're having a heart attack, so I'm going to look at the BNP. And what BNP identifies is the heart failure, the CHF. How bad is this? How bad is their congestive heart failure? So I'm going to go to I want you to turn to go to page A37. A37 in your book. When you see A37, you see cardiac enzymes and biomarkers. A is troponin. I'm not thinking they're having a heart attack. If I go to B, the BNP, brain natriuretic peptides, you look at where it says BNP and you go under number 3, right under the word measurement, and you see CHF. When they have an elevated BNP greater than 100, that's the normal value, number 2, I immediately say they have CHF. Less than 100 is normal, over 100 is abnormal, and then they qualify it mild, moderate, and severe, 300, 600, 900. And so how do you treat this CHF? Diuretics, positive ionotropic agents. So again, you forget, you go back to patient assessment and you look that up. Patient assessment is the key area, guys. Go back to J9. Based on your assessment of the patient, the scenario, the information, the hints that they gave you in the question, you now have identified what's wrong. First W. Second W is, what am I going to do? And what are you going to do? First thing is, they need oxygen. What are you going to give them? High flow. Right? The COPD was low flow. So there are 3 categories for oxygen. You have your COPD level 1. You want to keep it 24 to 28%, somewhere in that range for the COPD patient. The therapeutic range is a level 2. That's 30 to 60%. That's for everybody. You and I go into hospital, we have some pneumonia, have VQ mismatch. We're going to be put on an FiO2 between 30 and 60%. We never go over 60%. The only time you go over 60% is when you have an emergency. And when you have an emergency, it's 100%. High flow, non-rebreather, high flow nasal cannula, something like that. Does that make sense?
Yep.
It says place the patient in a Fowler's position. We talked about that. Why? Takes pressure off the heart. It's a CHF kind of thing. Hyperinflation therapy. Diuretics. Why would we give diuretics? We give it to go ahead and draw off the fluid that's built up in the lungs. Why are we doing the hyperinflation therapy? We want to put pressure in the lungs, CPAP, right? We want to put pressure in the lungs to prevent more fluid from going into the lungs. We're going to try to equalize that pressure so more fluid cannot back up into the lungs. Then it said positive ionotropic agents. There's your digoxin, digitalis, dobutamine, dopamine. You give that how much? Just give it to them. They're not going to ask you for a dosage. Okay. Analgesic, you're going to give them morphine. That's to help them feel a little bit better. But also morphine has cardiac dilatory effects. It helps open up some of the cardiac vessels as well to increase blood flow. So that's a good thing too. Then it talks about preload reduction agents. That's a nitroglycerin, nitroprusside, morphine, CPAP indicated to support oxygenation. That's what I was telling you,
Yeah,
right?
basal.
Mechanical ventilation with PEEP for vent failure. Once this patient is no longer able to ventilate appropriately, initially, if we looked at blood gases, it said respiratory alkalosis with hypoxemia. But we know that they're working hard to breathe. Eventually, they're going to poop out. Their respiratory rate's going to go down. pH will start to come down into the normal range. CO2 will start coming up into the normal range. Then it's going to go outside the normal range. When they're going into vent failure, you have to put them on a ventilator, right? And then you have these anti-dysrhythmic agents. Atropine for bradycardia for your heart rate too low. And then for tachycardia, you got procainamide or metoprolol. You can say the word. Those are the drugs that I would use. Either the heart rate's too fast or too low. All right. This is your CHF. And then I'm done with that. But again, what did I try to do? I tried to pick out the things that were very unique for CHF. You both have taken the test. Did you have CHF questions? Yes, you did. Flip the page. Did you have any MI questions? Anybody ever have an MI on your test?
I don't remember that one being on.
It's a possible. It's a possible. The CHF, pulmonary edema, is a definite. I'm going to show you that. But the MI is a possible. All right. Now I want you to go back to J3. J3. Put check marks next to 1, 2, 3, and 4. You're going to have asthma questions. You're going to have chronic obstructive pulmonary. You're going to have cardiac pulmonary vascular disease. You're going to have an infectious disease, some type of pneumonia on the test, how you treat them. I'd want you to go down to number 6, trauma surgery, highlight that. ARDS.
Yes.
Interstitial lung disease, ILD, and adult neurologic neuromuscular diseases. You know, like Guillain-Barré, myasthenia gravis, ALS. Okay. Go down further, skip lung cancer and geriatric care. Go to pediatric diseases, neonatal diseases. You will have something on those.
Yeah, usually like 2 questions.
And that's why it's lower on the list, on this list here. And then number 14, smoke inhalation. They like to ask questions about carboxyhemoglobin and hemoximetry and how are you going to treat the patient 100% O2 and
What kind of vent you going to put them on?
exactly. So I'm giving you those. I would definitely study the top ones first. Hey, could they ask you questions on psychiatric and bariatric and geriatric care? Of course they could. It's on the matrix. But the likelihood is so remote. I would rather you know asthma, COPD, CHF, pulmonary edema, those cardiac pulmonary vascular disease ones. I'd rather you know those like the back of your hand and then just forfeit the possible question on geriatric care or the bariatric condition or psychiatric disorder, because you're definitely going to have those up there. You're definitely going to have those questions. So in order to do well on those questions, you got to know the pathology. And hopefully today, with the time that we spent, what I've done was I went to the pathology in the back of the study guide and I looked at asthma first, and we beat up asthma. And you had to be honest with yourself, whether or not you knew it or you didn't know it. Regardless of what you've already done, it doesn't matter. My personal feeling, not to get too preachy, God wanted it for a reason. And now you're going to go ahead and you're going to find out what you need to know. All right. Maybe it was to help maybe prevent you from hurting somebody else in the future. All right. I don't know what it is. That's what I was actually telling my kids last night. You know, I'm not looking for the short way out because I really took my instructors by their word. You know, I wouldn't want to hurt anybody. And I hope that whoever's taking care of my family members would do the same thing. If we all do it, when I'm taking care of anybody you love most in the world, I'm going to give them my best. And that's all we can ask for. Okay. And so we identified the pathology. We identified the sequence. All right. We talked about the importance of the 4 life functions. We talked about knowing your pathology. When you come across something, when we come across something we didn't understand in the pathology going over asthma, we went back to patient assessment and I pointed out pages to you. You've got to understand that, right? And then you need to apply it, because if you're just reading it, I read through the book, right? Well, did you really understand it? Now, being honest, you can answer me or you don't have to answer me. Did you complete the whole full workbook? Did you do all 100 and something questions in the test your knowledge and look up all the answers? Did you take both practice tests that we gave you, which would help you identify your strengths and weaknesses? Then look up all the ones that you got wrong and retake those tests a second time. You're allowed to do that. And then the next thing is I would tell you, I would encourage you to go ahead and take the free MBRC practice exam, the one for this test that you guys are taking, not the new one that goes into effect in January 1st. This one. Every one of those tests, I want you to take in a particular way now. Now I'm shifting gears. Okay, I'm going to close out kind of on this. And so you want to take some notes on this. You might remember this from the seminar. And that was, you're going to have 160 questions, 140 count, 20 do not count. Okay. You have 180 minutes to do 160 questions. So you roughly, it's 1 minute per question. Now, what I have found out is that when students take this test, they feel like it's them against the MBRC. The MBRC is trying to trick them. How can they try to not be tricked by the MBRC? And every single question,
Janet Dunphy.
every question, can I call you right back? I'm in a Zoom. Okay, thanks. I talk to students and they talk about every question. It's a fight, right? Don't look at it that way. 160 questions, only 140 count, 20 don't count. What's the passing score, guys? 92.
92.
All right, you got to know that. That's your goal. It's kind of like any sport, anything like that. What is the goal? You've got to know what I'm shooting for. All right. And so I'm looking at this. My goal is at least a 92 so I can qualify for the CSE. All right, perfect. What do I need to know? Well, Alan said I need to know not only my patient assessment, but how they're applied to pathology. Alan then also gave me specific pathology that I've got to know. All right, that's perfect. Okay, good. So now when you're taking this test, you know I need 92 out of 160. The 20 I don't know where they are, so I have to treat all 160 as if they all count. Here's what I want you to do. Do you really believe that you're going to get 158 on this test? No, I don't think I would either. Even though I've been doing this, even though I'm the national director, I still make stupid mistakes from time to time. I think I saw something and it wasn't there. It's like my brain all of a sudden, it imagines something's there. And I sometimes go too fast for my own good, well-being. I've got to slow down. When I slow down and I follow this method I'm going to show you, my outcomes go right up. And so I'm going to know 1 minute per question. I know the target is 92 or better. That's the goal. I also know I'm not getting a perfect score. So that means, guys, if it's 160 questions, I can miss 68 questions. Let that number sink into your head. 68 times. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's 1. 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. That's 2. I can do that 68 times and I can still pass this test. That's a lot of wrong questions. 68 times you can say, I don't have a clue, and still pass this test. Right? It's not getting 100. It's not the MBRC against me. I got to show the MBRC what I know. So you start with question number 1. This is called the first pass. I start with question number 1. You read the question one time. If you know the answer, pick it. If you don't, I want you to skip it. You're allowed to skip. Only read it one time. You go on to the next question. You read that one time. If you know the answer, pick it. If not, skip it again. I want you to follow that sequence through the first pass. So I'm going to give you this example. I go through question number 1. I know it. I get through the first 10 questions. I read each of them one time and I knew the answer and I picked it. Not that I thought I knew it. I knew it. All right. I was certain I knew it. When I got to question number 11, I read it and I didn't know the answer. I'm skipping that one. And I'm going to go to 12. I'm going to read that one. And if I know it, pick it. If not, I skip it. I don't know it. I skip that one. I go on to 13. That's the way I want you to do it. Here's what I have done in the past. I would get through questions 1 through 10. I know them and I feel great. I'm feeling great about the test. I get to question number 11. I read it. I didn't know it. I looked at the answers and I'm like, okay, let me go back and reread the question again. And I reread the question and I'm looking at the answers. Then I go back to the question again. I'm trying to find an answer that would fit. Anybody else do that kind of stuff? Try to see if there's an answer that could work. And I've gone over and over with that question, probably read it 2 or 3 times. Now I finally pick something, and it's always A, B, C, or D. I finally pick something, and then I'm like, thank God that one's over, move on to 12. When I get to number 12, I didn't know the answer, so I go back to my same MO. I read the question, I read the answers, I go back to the question again. I try to make some answer work. Finally, I choose something. How do I feel about this test right now after 12 questions? Terrible.
Yeah.
But if I told you, you know what? 10 out of the first 12 questions, both of you guys, you're going to know cold. 100% certain you know the answers. How would you feel about the test then? Great.
Yeah, pretty good. Yeah.
Why do I feel so terrible when I have that same result? Because I kept on reading a question I had no clue about. And I'm reinforcing, I don't know. I don't know. I don't know. Here it goes again. I'm going to fail another freaking test. I don't know this stuff. How am I ever going to learn this? Why do they keep on asking me questions about this stuff? I don't ever remember studying this. This wasn't what I was told. We tell ourselves this narrative and we beat the hell out of ourselves. Correct?
Yeah.
Isn't that what you do? When really, all you had to do is get through the 10, 11 you didn't know, skip it. 12 you didn't know, skip it. 13 I knew, great, know it. I already know going into the test, I ain't getting a perfect score. I'm going into the test knowing I can miss 68 questions. Those are 2 I'm not even worried about. I just want to identify every answer that I know on that first pass, because inadvertently, unknowingly, when you kept on reading question number 11 over and over and over again, you said that that question was worth more to you, more to your score than question 160. You gave it more value, more of your heart, more of your time, more of your mental positive attitude. You put so much on that question number 11. And did the MBR say for you to do that? No. It might not even count. It could be one of those 20 questions that they're trying out new content that you have elevated to an equal value, when question 160 might be something like, what is the normal PaCO2 range? And you didn't give yourself time to answer that stupid question. You've got to use your time efficiently. So you go through all of the passes the way I'm showing you. Pass number 1, you do exactly the way I'm saying. Read once, answer it if you know it. If not, skip it. Get to the end. 160 questions. It probably took you an hour and a half to go through the 160, and say you answered 90 out of the 160. Well, you probably have already passed the test. You didn't get the high cut score, but you probably have already passed the test. You still have an hour and a half to do 70 more questions. So now you go to pass number 2. Now in pass number 2, you're never rereading questions you've already answered. You're only going to answer the questions you skipped on pass number 1. So I answered questions 1 through 10. Number 11, I didn't. I'm going to, on pass number 2, start with question number 11. Because I've already gone through the test, my mindset's going to be a little bit more positive. I might have been exposed to some information during the first pass that might help me to answer question number 11. And if I do, and I read question number 11 for the second time, I look at the answers. If I know it now, I choose it. If I don't know it still, know it, okay, I don't choose it. I have to know it, okay? But if I know it, I'm choosing it. Well, I skipped 70 questions on the first pass. I'm looking at these 70 questions on the second pass. Just for example purposes, I'm going to say that took me an hour and 10 minutes to do, right? So that means I have about 35 minutes, 45 minutes left, depending on where you are in that time, to answer the final questions. But on that second pass, I asked 35 out of the 70. If that is true, I should be at a point now where I've passed the exam. I go to my third and final pass. Those are the questions that I skipped on pass number 1, and I skipped them on pass number 2. We'll say number 11, I skipped on pass 1. I reread it on pass number 2. I skipped it on pass number 2. Now I'm saving it for the third and final pass. On the third and final pass, I'm rereading those questions that I skipped already for the final time. I'm going to do all the process of elimination. I'm going to do all this stuff, everything that I've been taught, test taking skill-wise, and then I am going to give it my best shot. I'm going to try to answer it as intelligently as I can. Alan said the 4 life functions. Alan said this. Alan said read questions in reverse. You know, when they're very long, read them in reverse, because when you do that, you can look at the answers, and many times the answers will point to you where you have to get your information to answer those long questions. But on that final pass, I am going to go ahead and answer it. If I don't have a clue, I'm guessing. Scott uses letter A, the owner of the company. I use letter C. That's just me. Scott says the reason he uses letter A is that he's already read this question 3 times, and he can't remember the answer. He can't come up with an answer. It's probably one of those 20 questions that the MBRC is throwing at them that don't count. So the MBRC can go ahead and kiss my A. And he's keeping it in perspective. He's keeping it in perspective. Why? He remembers 20 questions don't count. It's not him against the MBRC. It's him showing the MBRC what he does know based on the questions they give him. He also remembers he doesn't need a perfect score. He needs a 92 or better. So it keeps him positive. And so on the third and final pass is the only time you skip a question, right? No, pardon me. Third and final time is the only time you guess at a question. You never guess on pass 1. You never guess on pass 2. You only guess on pass number 3. At that point, it is what it is. If you knew your pathology the way I've said it, and you knew your patient assessment, you're good to go. And I would tell you, like, you do that, then the next areas where we would have to come together and talk would be, you need to do, mechanical ventilation, be able to look at in a blood gas. And when you see a blood gas, you have to say, are they ventilating? Yes or no? Are they oxygenating? Yes or no? Do they have an acid-base problem? Which one do I treat first? Always you treat ventilation first. You have to be able to do that. And then if they're on the ventilator, you have to identify what changes would I make. How would I set up the vent? How would I make changes on the vent? And then how would I wean the patient off the vent? That was where your second largest, that's really where the largest amount of questions come, is based on mechanical ventilation. But you can't do mechanical ventilation without understanding your patient assessment.
Yeah, they say those two make up really like 60%, 66%.
It is. It
They
is.
say if you know those two real well, you can pretty much pass the exam if you just know those two very, very well.
This is mechanical ventilation, pathology, and patient assessment. That's it. You could, if you came back to me and you took the test and you said, I didn't pass, I did a lot better on mechanical ventilation. I did well on, I can't remember any pathology type questions that I struggled on. But boy, when I do the assessment test, I stink at pulmonary function testing. Well, that's where we focus our attention. We just go ahead and we focus on that so that you do well. So that's why you take the practice tests, not just to say, oh, did I do well? No, all of the practice tests, all of the stuff in the workbook and the tester knowledge and our practice test and the MBRC test, that's supposed to, for you to identify what you do know versus what you don't know. So you never guess on those tests. Like when you did the pre-test, we don't want you guessing on those 30 questions. We want you to just to identify what do you know versus what don't you know. And, most of the time students do very poorly on that. But this is very doable, guys. I would tell you, I would look at your patient assessment. I looked at in relation to just knowing at least the first 5 pathologies. And of course, ARDS, that's going to be important. They're going to ask questions about that. And then, like you said, you need to know mechanical ventilation. You need to know how to, that box. And if you go to section E, not section E, yeah, section E, go to page E11. Now, on the previous page, you have all of those ventilatory measurements. You'd have to know those two. Those are in boxes. But when it comes to mechanical ventilation, setting up the ventilator, you need to know that box where it says tidal volume, pressure, respiratory rate, FiO2, and P. You've got to know that. And then, do you know how to calculate ideal body weight?
Mm-hmm.
All right, good. So that page, E11, is a must. Go to, and then the examples on E12 means that you know how to do it. The next page, E13, is a must, setting up a baby on a vent. You need to know that box. So E11, E13. Then that's the end of phase 1, putting a patient on the vent. Phase 2 is caring for the patient. That's where the majority of the questions come from. Caring for the patient. So if you look at A, number 1, vital signs and patient assessment, A through K. If you can't do that, you're lost. And that was me telling about associating with pathology because then it means something to you. A through K. Then you're going to take measurements while the patient's on the vent, spontaneously breathing. That's A through F. Then it talks about minute ventilation, alveolar ventilation. You have to understand that. If you come to A15, this is the next page. That's really important. You see 2 boxes. I'm sure you're familiar with dynamic compliance and static compliance. No static compliance. That's the one that's important. All right, so you know the formula there, exhale volume divided by plateau minus your PEEP. Highlight what normal is, that's B. Your static lung compliance is 60 to 100. And then you know that when pressures are going up, the patient's lung conditions are going down. So higher pressures are bad, lower pressures are good. We all follow that?
Mm-hmm.
That box, when the pressures are going up, it's either due to increased airway resistance or a decrease in lung compliance. Those are the 2 things that you have to be associated with. If it's airway problem, 2 things. You're going to see your PIPs going up plateaus stay the same. PIP's going up, flats are same. It's either due to secretions in the airway or bronchospasms. So what are you going to do? Suction the airway, give them a breathing treatment. If you do both of those, you should see your PIPs come down. But what if your PIPs are going up and your plateau pressures are going up? Then it's not an airway problem, it's a lung compliance problem. How do we treat lung compliance problems? It's a four letters I'm looking for. PEEP.
PEEP.
And then treat the underlying condition. Once you identify it's a lung compliance problem, PEEP.
PEEP.
Okay, and you can see that down below. C, common causes. These are all for decreased lung compliance, and the treatment is increase your PEEP and treat the underlying condition. Now, the MBRC will always give you PIPs and plateaus. You need to know how to use them. They're always going to give you a PIP and plateau pressure and a problem. You need to know how to use them. So if you look in that box, the one at the bottom of the page, letter E under increasing airway resistance, raw can be estimated by doing PIP minus your plateau pressure. So if they give you a PIP and a plateau, subtract it, and then that is your airway resistance. They give you a number at 8 o'clock, and then they give you one at 10 o'clock, and they give you one at 12 o'clock. If you see that number going up, treat their airway. If you don't see that number going up, but you see the plateau pressures going up, then you know it's a decreased lung compliance. Go up on your PEEP. Okay. You can read through mean airway pressure. This is E16. Just know 4A, the controls that affect mean airway pressure. Mean airway pressures are not bad. They can be bad. They can be indicative of a problem. But mean airway pressures can also help with oxygenation. But I want you to know when your mean airway pressures get too high, what controls will have the most effect on mean airway pressure? That's number 4, PEEP. PEEP, most influence on mean airway pressure. You want to highlight that. What are normal airway pressures? For you and me, we go in the hospital, we're on a ventilator. B1, 5 to 10 is normal. If the patient has obstructive lung disease, it's 10 to 20. And if they have ARDS, it's 15 to 30. So what do we identify there? Low mean airway pressures are good. High mean airway pressures mean lung problems. That makes sense? So we just need to know 5 to 10 is good. Greater than that, I've got a lung problem. Then I have to treat it. The next page is just secondary modes of ventilation. All right, I know you know assist control. I know you know SIMV. Got to make sure you review those. Secondary modes, you're only responsible for A and B. PRVC is not on your exam. You're not responsible for PRVC. So that would be a wrong answer. When you look at A, inverse ratio ventilation, all right, look at number 2. Why would I change a patient from assist control, volume control, or assist control, pressure control to a secondary mode? Or why would I change it from SIMV, volume control, to a secondary mode? Well, the reason I'm doing it is I've kind of maxed out my settings in the primary modes of ventilation, and now I have to look at a secondary mode of ventilation to help improve oxygenation gas exchange and help me decrease those high PIPs and PEEP levels. That's number 2 under A. Who would I want to recommend? Who would qualify for this secondary mode? That's 3, A, B, and C. Patients with high FiO2s greater than 60. Remember I said I want us to go up to 60. We can't go over 60. If they're over 60, that's bad. If their PEEP is over 15, that's bad. If their PIPs are greater than 50, that's bad. And we still have, with all of those high settings, we have a low PaO2 and decreased lung compliance. When I see that on a patient who is on assist control, volume control, or SIMV, pressure control, whatever the primary modes are, if I see them on there and they're getting those kind of results, I know the primary modes of ventilation are not working. I've got to choose something else. One of my choices is inverse ratio ventilation. What is normal IE ratio, guys?
2 to 1. 1 to 2. You said
1 to
normal?
2, 1 to 3.
Yeah, 1 to 2, 1
Right?
to 3.
So now I'm going to do the inverse of that. What's the inverse of 1 to 2? 2 to 1.
2 to 1.
So you can go ahead and highlight number 5. That's what you would start with. And the reason I'm putting them in this inverse ratio mode is because I want to do number 2. I want to help improve their oxygenation, their gas exchange, while decreasing that high PIP that they were on, greater than 50, and their PEEP levels, which were greater than 15. I've got to bring them down. That's great. Okay. Now with this mode, I don't know if you've ever tried to breathe the opposite way. You breathe right now 1 to 2, 1 to 3 normally. Try breathing the other way. Longer for inspiration and give yourself half the time to exhale. Very uncomfortable. So these patients need to be paralyzed and sedated. You need to know that. That mode you can be responsible for. The other one is B, APRV. You need to know that. And this is just like CPAP. We have an elevated baseline pressure and we let the patient spontaneously breathe. This results in lower PIPs and it also helps lower mean airway pressures. And the criteria for going on APRV, guys, is the same as number 3 under A. So if I had a question, all right, here's an MBRC ventilator question. You're a respiratory therapist working at a 300-bed suburban hospital, and your patient's been on assist control, volume control, blah, 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 blah. Their FiO2 is 65%. Their PEEP is set at 17. Their peak inspiratory pressures are 60, and their P little AO2 is 49, and their lung compliance is decreased. Which of the following would you suggest or recommend to the physician? Switch them to IRV, switch them to APRV, switch them to PRVC, flip the page, or switch them to PAV plus. That's the other mode. These are your 4 secondary modes. Here's how I process that. This patient's PIPs, FiO2, PEEP, all too high. I want to give the lungs some time to heal. So I'm going to put them on a secondary mode. Immediately, I'm going to cross out PRVC because I'm not responsible for it. It's no longer even a choice. I'm going to look at PAV plus, which was on the next page. I'm not going to choose it because I'm not responsible for it. So I've eliminated 2 answers already. That leaves me with IRV and APRV. Every single day of the week, I am going to choose APRV over IRV. And the reason is I don't have to sedate and paralyze my patient. I want them to be able to participate in ventilation. When you paralyze and sedate your patients, that creates more problems as well. So from that, I had 2 good answers, IRV and APRV, but one answer was even better, and that was APRV. Why? Because it does all the things that IRV does without sedating and paralyzing. And that would be my answer. Does that make sense?
Yep.
All right, good. So you want to read through that. Then number 3 on E18 talks about what are your spontaneous breathing options. I'm sure you're familiar with CPAP, pressure support, and volume support. Read through those. Now, at the bottom of E18, have you guys did you remember any type of areas where they talked about high frequency oscillation ventilation?
Mostly with like kids, and you just got to know like frequency with the frequency. If you actually want to like turn it down to what's the terminology? Like if you're turning it up, you're turning it down. If that makes sense, you lower it.
That's what you're looking at. Number 5 on E19 frequency.
Yeah.
It's a secondary control of PaCO2. If you lower the frequency, you're going to result with a higher tidal volume. They're inversely related. You have to understand how the oscillator works. And the oscillator is sending pulse pressures at very high rates. And like you talked about the frequencies, I would know number 3, how the breath is being delivered. It oscillates gases at high frequencies, 3 to 15 hertz. You could be asked to calculate this. 1 hertz equals 60 cycles. How many breaths are in 5 hertz? That's 300 breaths. You could be asked to calculate that. But number 5 is where, like you're saying, how would you make an adjustment? The best way to make an adjustment on CO2 is with the amplitude, where you would just increase the amplitude. That's the primary way of adjusting CO2. The secondary control for CO2 is adjusting the frequency. All right. The higher the tidal volume, because when you stop pulsing that breath in and out, what you're doing is holding the breath in the lung longer. When you hold the breath in the lung longer, it's like lung recruitment. It pops open alveoli, which results in a larger volume. That's a secondary control. You see, it's not usually adjusted. The primary adjustment is normally amplitude. For O2, you're going to adjust the mean airway pressure, and then FiO2, you're going to set it up the same way you do for conventional ventilation. Whatever they were already on, you're going to put them on that same FiO2. Here's something that somebody told me to help me understand high frequency oscillation ventilation. I want you to think it's a really cool, really great late spring day. Temperatures are around 75, 80 degrees. You're in your car and your absolute favorite song comes on the radio. What do you end up doing? You turn it up, right? You increase the volume. Well, you're not going to increase the volume. I'm going to crank up the amps. If I crank up the amps, what have I done to the volume? I've increased the volume. So when you go up on your amps, you're going up on your volume. Same thing. If you ever pulled this circuit apart, you will see it looks like a bass speaker. Old-time bass speaker that you would see looks just like that, and the circuit sits up to this bass speaker. So if you want to decrease CO2, you want to increase your amplitude. Why? When I increased my amp, I increased my volume, just like in music. I increased the amps, I increased the sound. That make sense?
Yep.
Mm-hmm.
All right. Another unbelievably important box when it comes to questions is correcting ABGs. That's this box right below that, E. Do you remember questions? They give you a blood gas and you had to make some kind of change.
Yep.
You're going to definitely get that. You've got to know this box inside and out. Now, I will tell you, we tell you 5 to 10 mLs per kg for the tidal volume. Rate 10 to 20 breaths per minute. Let's just look at that for a second. If you go ahead and you find out, you look at the problem, and the patient's CO2 is high, you know that they're not ventilating well enough, right? So that means you either got to adjust the tidal volume or the respiratory rate, the frequency. When you look at your vent settings, the tidal volume is set at 7 mLs per kg, and the respiratory rate is set at 10. Well, you have room to make changes on both. Which one's at the higher side of normal for settings? The tidal volume, right?
Mm-hmm.
Because 5 to 10, MBRC loves 6 to 8. So 7 mLs per kg is on the higher side, and the frequency is 10 to 20. And I said the rate was set at 10. That's on the real low side. Since one is already on the higher side, I would choose the respiratory rate answer. Go up on the respiratory rate. Okay. Does that make sense?
Yeah, those get a little bit tricky sometimes too, because like you said, they want you to continue to mess with the volume when the more appropriate choice, like you said, is to go up on the respiratory rate.
Yeah, but you have to know what you would normally set the patient up on. We use 5 to 10, right? So I use 5 to 10, 10 to 20 for the rate. I get the patient's not ventilating. The patient's tidal volume is at 8 mLs per kg and the rate is set at 12. I'm going up on the rate. I'm not going to go up on the tidal volume.
Mm-hmm.
Okay. Or I have the tidal volume set at 6 mLs per kg and the respiratory rate is 17. Well, I'm already at the higher side for the rate. I can bump
rate.
up that tidal volume a
volume.
little bit. You got to
Mhm.
use your common sense there a little bit. Okay, it's not ironclad. You kind of have to adjust it. Now, here's another thing I'm going to tell you. Actually, I'll wait. When it comes to lowering, right, you want to normalize a low PaCO2, you have to make your adjustment. Think the same way as you did for increasing. You have to look at your tidal volume range and you have to look at your respiratory range. If I'm already at the high end for my tidal volume and my respiratory rate, say I'm at 8 mLs per kg for my tidal volume and my rate is 15. All right, that's in the middle, but my tidal volume's up at the high side and I have a low CO2. I'm probably going to back off the tidal volume a little bit. I'm going to bring that down a little bit because it's good to have them both in the middle then. Does that make sense?
Mhm.
FiO2, when you want to normalize a PaO2, you're going to increase your FiO2 by 5 to 10%, but you never go over 60. Once you get to 60, you're going to have to go up on your PEEP.
Yeah.
Choose a PEEP anywhere between 2 to 5 centimeters going up.
Mhm.
Okay. Let me give you this. What happens when you have two answers that work? Give you an example. Patient's not ventilating. Their CO2 is 60 or 55. Their tidal volume is set at 8 mLs per kg. Respiratory rate is set at 15, and rate is set at 15. FiO2 is set at 40%, and PEEP is set at 3. You notice that they're not ventilating. You get two answers. Increase the tidal volume. That would work. You can go to a PIP, you can go to a 9 mLs per kg, 10 mLs per kg, or you can increase the respiratory rate. Well, they didn't do anything with the rate. They only gave you two tidal volume answers, right? The only parameter that we're changing was your tidal volume. One answer said go from 8 to 9, and the other one said go from 8 to 10. Always be conservative. Go with the lower number.
Mhm.
Okay. Patient's problem with oxygenation. Vent settings are all the same, but one setting says go up on the FiO2 from 40 to 50. The other one says go up to 55. Be conservative and go with the lower number. Always be conservative when you have more than one answer. Does that make sense?
Mhm.
Yeah.
We got to remember that your patients are not going to be not going to die. You're going to have time to make changes. So that would be manipulating your vent. And then another area that's a really important area for the MBRC is vent graphics. You see E21 in your book
Yeah.
through E27. You're going to get some questions on the graphics, how the patients enter. You're going, and you have to know this. If you don't, you're lost. All right. So that is really important you to know. And what we do is we're giving you two graphs, right? Looking at E22, the one at the top. The one on the left is the problem. The one on the right is after it's been fixed. All right. So you're looking at adjusting PEEP level. The one on the left is the wrong. That's where the problem is. After it's been fixed, that's the graph on the right. Next to number one, you can write the word problem. Next to number two, you can write the word fixed. That's the words that are used to go fix the problem. After it's fixed, what happens? When the PEEP is increased to 10, the shape of the curve is now normal. The optimum PEEP for this patient, therefore, is 10 centimeters of water pressure. And it follows that sequence. Again, go right below that. The graph on the left is the problem. The one on the right is after it's been fixed. The words underneath, number one is the problem, number two is the fix. So when you're on your own and you're studying, you can look at that graph and say, okay, that makes sense. And then the answer makes sense. Top of the next page, lung compliance problems. What did we say fixes lung compliance problems? What addition, what do we have to increase in their vent settings to help improve lung compliance?
Pete.
Pete. So there you go. Look at number 2, the fix, right? The volume pressure loop on the right shows the compliance improving with Pete therapy. And so you have to know what the graph looks like and know what the words. And it follows that same sequence through the rest of these graphs. I would tell you, you could see all of them. I would definitely tell you, I would be more than certain you will see E25, air trapping. You will see some type of air trapping where the patient's not given enough time to exhale, and you have to be able to identify that from the graph. If they're not reaching baseline again before the next inspired breath, then there's a problem. If you look at that graph there, right before number 1 is a little line. You see where it starts to go up. Then when it starts to go down, that's the end of I, inspiration. And then exhalation, it starts to slope upward. But right before that number 2, did it make it all the way up to that line?
No.
No. That's indicative of auto peep. That's bad. When I don't see the exhaled breath going back up to where we started, which was the baseline right next to 0 and that halfway mark through the number 1, it started at 0 pressure. But the next breath didn't start at 0, it started below. That meant I'm trapping air. So you don't want to do that. Number 1 is air trapping. That's what I just explained to you. Number 4 are all the other terms that the MBRC uses for air trapping. And then number 5 is why it's so important to know, because there's nothing good about air trapping. There's nothing good. It's all negative. The key here is what's wrong? They're air trapping. What do I do? Stop them from air trapping. How do I do that? Go down to number 6. I can decrease the I time. If I get the breath in quicker, I'm going to give the patient more time to exhale. You remember IE ratio is 1 to 2, 1 to 3. You know that like if a patient's getting 12 breaths a minute, the total cycle time for a breath is around 5 seconds. How did I get that? I just took 60 and divided by the 12 breaths. 60 divided by 12 is 5 seconds per breath. And if I do an IE ratio of 1 to 2, 1 to 3, all right, 1 to 2, I'm giving 1 part for inhalation and then 2 other equal parts for exhalation. I'm not getting it here in this picture that you see here. You can see that inspiration is much longer than exhalation. So how do I fix that? I decrease I time and make E time longer. The other thing you can do is you can increase flow rate, right? But do your ventilators have a flow control knob? No. What do you set your ventilators up on, guys? 0.9, 1.0 for an I time, right?
Yeah.
So I'll give you an example. If you set the I time at 1 second to deliver tidal volume of 400 cc's, if you go ahead and change that I time from 1 second to a half a second, you're going to get that tidal volume of 400 cc's in the lungs in half the time. And the only way to do that is by the ventilator adjusting the flow to get it in there even faster. So if I go down on my I time, that's the same thing as saying I'm increasing my flow rate. Does that make sense?
Mm-hmm.
You got to think about it for a little bit because all of these here are saying the same thing. Look up above where you see the graphic. You see where it says I with the arrows, hash mark to hash mark, and then E. Well, the I plus E is the total cycle time for the breath. And obviously the E ends below the baseline. I need to give the patient more time in the E area. What do? I take it away from the I area. All right, we back up that so that the inspiration ends quicker to give the patient more time to exhale. Well, that is the same way of increasing the flow rate. Or you can increase the E time. The only way to increase the E time is to take it away from the I time. If I decrease the I time, right, that's the same thing as having the E time increased. Does that make sense? They're all saying the same thing. You could consider changing modes when the patient is hyperventilating, rates over 20 breaths per minute. Then you might want to consider maybe going from an assist control to a SIMV mode. And then the last thing is consider sedation and paralyzation. But that's the last thing you want to do. You will definitely see questions on that. And then how the patient is triggering breaths. E26, you see the patient's trying, and then they really try. You had to identify the sensitivity level is not set appropriately. The patient shouldn't have to adjust to the vent. The vent should adjust to the patient. The next page, you have auto cycle, breath, 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 breath. That typically means your sensitivity is set wrong. Adjust your sensitivity. And then lastly, on E27, you'll see the patient triggers a breath and they're going up, and then all of a sudden it dips down. Wherever you see a little dip down, that means that they're flow starved. And that is your phase 2. Phase 3 is your, you see there's not that much. It's a page and a half, and this is going ahead, weaning them off the vent. You need to know how to do weaning parameters to show that the patient's ready. And you need all 4 of these on page E29. Good blood gas is showing good ventilation, oxygenation, good bedside ventilatory parameters. I definitely would know the RSBI, your vital capacity, and your MIP at a minimum. Right? It's a box. It'd be great to know all of them, but those at a minimum. RSBI, vital capacity, MIP. All the clinical measurements have to be within normal. They can't be severely abnormal. And then the reason that you put the patient on the vent needs to be reversed. It no longer needs to be there. If you can say yes to all 4 of those, then you're going to go ahead and do the weaning parameters. That's page E30.
You said RSBI, vital capacity,
MIP.
MIP.
Mm-hmm. It would be good to know the others, but that at a minimum. Okay. Once the patient, you can say yes, 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 yes to all 4 of those, then you can go ahead and recommend let's do the spontaneous breathing trial. That's on page E30 and 31. So you see B on the top of E30. You're going to administer CPAP with or without pressure support. Maximum trial is going to be 2 hours. Then you see the criteria for stopping the SBT. You've got to know when to stop. That's where a lot of questions end up coming. You see the patient, they're not tolerating the spontaneous breathing trial. And then what are you supposed to do? Right? That is number 6. Return the patient to mechanical ventilation for 24 hours and rest them overnight. That's not what they do in the hospital. Physician walks in the room, they say, pull the ET tube and put them on a nasal cannula. And that works, but you can't do that. Not on the MBRC test. You've got to follow this protocol. Okay. What are the weaning methods? You see them listed under C. MBRC loves SIMV with pressure support. And then D talks about the drugs that suppress ventilation. They should be stopped. That makes sense. What are you monitoring during the weaning trial? That's the top of E31F, your heart and lungs. You're monitoring the heart rate for increases of beats of 20 beats or more from baseline. If that happens, their heart rate goes up 25. Stop the weaning, put them back on the vent. If their heart rate goes up, but it's not over 20, it's say 15, continue the weaning process, just bump up the FiO2. And then every 20 minutes, you're going to be monitoring blood pressure, respiratory rate, tidal volume, and vital capacity. If the patient does well, then you can pull the tube. If not, you put them back on the ventilator. You need to know that. Okay. Under sensorium, of course, you want them to be participating and aware of what's going on. Other assessments, you can read through that. Just remember, we want to monitor urine output. We want to make sure that the patient's voiding their fluids appropriately. Now, I would tell you in closing for today, we've gone over the importance of patient assessment. We've gone over the importance of pathology and then mechanical ventilation. I would be spending time today, or when you're studying, pick pathology, right? I'm going to learn asthma, and then I'm going to go back to patient assessment. I'm going to make sure I know all the terms related to asthma. Then I'm going to go to my normal values. All right. That's in the back of your book. You'll see your normal values in your book. This is appendix number 3, section K. Go over the ones that are related to the pathology you're talking about. You know, heart rate, adult, normal is 60 to 100. Well, the patient's tachycardic, that means the patient would have a high heart rate. You know, breath sounds, vesicular, what's that mean? Heart sounds, blood pressure, ICP, no, that's not here. CPP, no, that's not here. Exhale carbon, nope, that's not here. Going down this list, making sure you know the normal values for asthma. You flip the page, I'm going through, well, you know what? None of this is here. I'm not doing the infant assessment here. Hemodynamic monitoring, probably not doing any of that for asthma. Going to do airway care. Well, if I had to intubate the asthmatic, I'm going to keep my cuff pressures there. What kind of blade would I use for an adult? Size 3. What if this was an adult male? What size tube would I use? 8 to 8.5. Adult female, 7 to 7.5. Oral intubation, where would the mark be for this adult asthmatic? Boom, there it is. You know, pulse oximetry, what are my normal sats, right? I'd come over to the next page because nothing else on that page is related to asthma. I come over and look at my oxygenation formulas. That could all pertain to asthmatics. Look at my ABGs. I'd want to make sure I remembered my normal ABGs. I'm not doing anything with normal arterial blood gases for neonates. Pulmonary function, right? Calibration syringe, you'd have to go through it because this would be appropriate for your asthmatic because it does talk about the FEV1 and FEV1% measurements. So I would review the 2 boxes there, right? And then mechanical ventilation. Well, we're dealing with the asthmatic. Here it says 5 to 8 mLs per kg, but they told me 5 to 10. Well, we're doing that because it simplifies the math. If I get 2 answers, I'm always going to choose the lower one. Okay. But there was something for the asthmatic that we had to point back out. And that was back on page E11. E11, below that important box, if you look at B, it says for patients with severe asthma, we want to recommend the initial tidal volume at 4 mLs per kg. Highlight that. That's specific for the asthmatic. So if you had to put an asthmatic patient on the vent, that's what you're going to use that tidal volume. But you see how I'm studying my normal values in relation to the pathology? Eventually, I'd like to have check marks next to all of them that I know. And I'm relating them to the pathology. Your calculations are the next section. Any of the things that would be appropriate calculation-wise, you'd want to look at that. And once you've done that, then you just review those important pages, E11, E13, stuff like that for those vent boxes. So then when you sit down, you write that box out and you use that. You do a brain dump on the white sheet of paper, any of the things that you're going to have to use, because you know, once you start getting hit with questions, you could lose your train of thought and get frazzled a little bit, and you'd forget things that you already do know. So you want to do a brain dump for the first few minutes and write it all on that paper. And then lastly, guys, and then we'll finish, I went over the 3-pass method. You guys have got to use the 3-pass method. Make sure you've done the whole workbook. I'd write answers in an old notebook. do the test your knowledge quizzes. Do both of our practice exams if you haven't done them twice. Set up the same environment. Sit down in front of your computer. I'm going to do the practice exam by Kettering. I'm going to give myself 3 hours. Here's a calculator, and give yourself a white sheet of paper and a pencil. Use the 3-pass method. Practice that. Every answer you don't know, look it up. Look it up. Look at the evaluation at the end, the things that you're struggling on, and then look that up. Anywhere that you're still struggling, set up a tutor time. But you guys will have to do this probably since, I mean, Richard, you told me it's been about a month. You've kind of not looked at this stuff. All right. I don't know how long it's been for you, Ruben, but
I've been at it pretty much every other day, and I actually have my my exam Friday.
This Friday, okay.
Yeah.
Well, then hopefully this had helped today. I would definitely take that 3-pass method, but I would think that you guys have to be doing this a little bit every single day.
Yeah.
Probably for at least 20 hours a week. At least 20 hours a week. Once you've gone through all this stuff, you want your best chance, then, do the things that we've said, set up for the test, make sure you feel good with those pathologies, that your ventilator boxes, that key information, and your normal values, and you should be good to go. Realize again, you don't need a perfect score. All you need is a 92.
Yeah,
Have you guys found this helpful at all today? Has this been helpful? Has this been helpful today? Yeah, I would tell you, and my encouragement, if you were already using Lindsey Jones and you were going to continue to use Lindsey Jones, I wouldn't dissuade you. You already bought it. I'd say use it. All right, because I'm really a big proponent. When you use multiple systems, you get confused. But you're using us, so I would advise don't use anybody else. Continue to use us. Help us. Let us help you get across that finish line. Okay, let's do that and use the tutor line. But hopefully it helped today, guys. I know it's been about 2.5 hours, 3 hours we were on.
I'm gonna let you go, Mr. Dumpy. I tried to schedule an appointment. Their dates was kind of booked out until like the second week of September.
All right, so, go back to info@ketteringseminars.com, the email, info@ketteringseminars.com. Tell them you can't find a tutor time and your test is this Friday. You need to speak to a tutor.
Okay.
And they will organize a tutor to be there with you.
Okay. And then my last question.
I got a couple of minutes. What was one of your questions?
One student was having trouble getting on, and she wanted to know if you was going to possibly like do this again, possibly, if you could.
Well, I'm going to be doing it for another college, and then I'm going to try to do this maybe once a month. All right. And then I'm just going to open it up to everybody. It's hard for me to take 3 hours out of my day to do this, but I would like to be able to help support you guys this way. Your program director and the faculty, they have really advocated on your behalf. And the biggest thing that you guys can do is do the work. We can't do it for you. I know I can put my head. What was that?
Ruben, I taped this whole entire thing. So tell them to email me. Okay.
Okay.
And if you guys want it, you got to email me and I'll send it to you guys. I got permission from Alan to do so.
Yeah, you guys.
I didn't expect it. Alan, you spent 3 hours and 30 minutes. You did more than you thought. So thank you so much for your time.
There's so much I could spend another 12
I know.
or 14
I can tell you love it. I know you love it.
I've got other things that I'm responsible. I'm sure you saw me get a couple phone calls while I was doing this.
I know. I thank you.
There's going to be a few people
this is a gift
PO'd.
And they know it. And I'm like pulling for you guys.
We can
so
help
I really
you.
want you guys to be successful. So I'm always here. I just talked to Alan and we came up with this. So I hope it helped you all.
Yes, it was very helpful.
Okay.
Yeah, great work.
Now,
all right.
Patricia, do we have another meeting?
I don't think so. Do you want another one?
I had you twice in my calendar.
No, we don't have
another meeting. For some reason, I had it today, and I put it in my Zoom calendar for some reason. So I logged onto that first, I
Oh,
forgot
no,
that it was a Teams, and then I had you
No.
next week too, but that's probably
no, we're good.
something
We're
else.
good.
All right, perfect.
Thank you so much. Thanks, guys.
Thank
Good
you,
luck,
guys.
Ruben. Good luck,
Best of
Richard.
luck, guys.
Great work. Appreciate it.
Bye-bye.